we do have at the moment 25 various chapters that are published here. And first of all, I would like to give you some information how you can access those guidelines. You just have to go to the EAU website via euroweb.org, and then you get access to the guidelines. It's absolutely for free. There is no need for you to be an EAU member to access the guidelines. So when we are talking about pediatric urology guidelines, then the first question we have to address is, are guidelines in pediatric urology really needed? Because producing such guidelines is extremely time consuming. It does demand a lot of various resources and manpower. In addition, it's rather expensive. And once you have published such guidelines, then continuous evaluation and revision of the guidelines is definitively a must. The next question is, who wants such a guideline in pediatric urology? Well, of course, the healthcare professionals, that's for sure, but also other people like stakeholders, affected patients, and since we are dealing with children, their caregivers, of course. So the question is there really a public health perspective in producing such guideline? And how can we adopt regional needs to global ones when we are producing guidelines that should be worth in the whole continent of Europe or even worldwide? And of course, when we are starting to produce guidelines, you always have to ask the questions, do guidelines in that field already exist? And then, of course, is the European Association of Urology the right organization to produce such guideline? Is the EAU in the best position to develop guidelines on the topic of pediatric urology? And is that, of course, within the scope of the European Association of Urology? Or is maybe another organization better suited to produce such guidelines? So what will our guidelines achieve? Well, it will, of course, address poor practice. It will probably help in changing of program approaches and health policies. And it will direct the users in fields where they feel still uncertain. So specific objectives of the guidelines are, what health indicators or other measures do we want to improve when we are producing such guidelines? Who is our target audience? The end users of our target audience have to be clearly defined. And when we are coming to the recommendations in our guidelines, they need to be tailored to that audience. That's very, very important. And the end users are usually those who apply the guidelines, and they are not the recipients of the recommended intervention, because the recipients are our patients. So that's a huge difference when we are looking at the recipients of the intervention. Who are the people whose health and well-being will be affected by the recommended intervention? And we have to pay attention to their perspectives and to their needs. That's really a must. And that needs to be built into the guideline developing process from the very beginning. And patient-reported outcomes are definitively relevant and in addition extremely helpful to further improve the quality and then especially the adherence to guidelines. What are guidelines worth if people do not adhere to what we are recommended? So will the recommendations in the guidelines be implemented? The purpose of us is to improve health and well-being, that's for sure. So therefore, the guidelines have to be disseminated, adopted, and the recommendations implemented. So who should be involved in developing a guideline when we are coming to that point? Well, definitively, it's a collaboration among a large number of people and groups. It's not only that 5 people meet in a room and write the guidelines over a weekend. It's really a collaboration among a large number of people and groups. And expertise is definitively mandatory. So the problem is to identify such people and groups. So that means there is a risk of bias from the very, very beginning when you are trying to identify people and experts who can help in producing such guidelines. And at the very beginning, you always have to ask the key questions. You have to identify, assess, and synthesize the evidence that is available. You have to perform systematic reviews and meta-analysis. And then last but not least, all the evidence that is there needs to be translated into final recommendations. And there are some additional considerations that need to be taken care of when producing guidelines. You have to convene meetings, long hours of dedication, and of course, everything without any remuneration. All the experts that are involved in the production of the EAU guidelines, they do it for free. They are offering and spending their time for it. But of course, the organization has to cover the production costs. And then there is the question, how should we publish it? What types and formats? Well, the EAU guidelines at the moment, they are available either as a book or as a pocket version. You can access the EAU guidelines via an app or via the web. And then there is one more big question. You know that there are a lot of different languages within Europe and around the globe. So planning of translations is also a very, very important issue. And last but not least, that needs to be done from the very beginning. You have to declare and manage any conflict of interest of the people and groups involved in producing the guidelines. So when it comes to producing guidelines in pediatric urology, the guidelines you see on the web or on the app or in a book, this is just the top of the iceberg. But below the level of C, there is a lot of work. It's dedication, it's hard work, discipline, disappointment, sacrifice, failures, persistence, and all those things are important and issues that are involved in producing the guidelines. So we have to scope the guideline. That is the process of defining what the guideline will and, more importantly, especially in sometimes, will not include. And scoping is one of the most difficult but important aspects of guideline development. Because if the scope is right, then the end product is relevant to the end users. And this is one of our main goals. If the scope is wrong, then resources and a lot of money are wasted, and the end users will remain uncertain about optimal intervention or approach. So how can we scope then the guideline? Well, initially you have to draft a potential scope, to have to refine the list of priority topics. That means we do not want to include everything because we do not want to write a textbook. That is something absolutely different. We want to concentrate on topics in which a change in practice is desired and feasible. We do not want to concentrate on areas where inequity, controversy, or uncertainty is existing anyway. We have to search the literature almost on an everyday basis. And then we have to sharpen the focus. We have to consider equity, human rights, and gender, which is indeed very important. Then we need to review everything and then reconsider and start the process from the very beginning on. And this flowchart that I have put together here is just a very, very simple, simple diagram to show from the very initiation how to create a draft clinical practice guidelines, from draft to the final clinical practice guidelines, then dissemination and implementation, and then very important, you have to maintain the quality. That means routine searches for new evidence is absolutely a must. And especially since 2 years, you have to react to special situations. Think of the COVID-19 pandemic, which changed absolutely a lot all over the world. When it comes to dissemination, once the guidelines are finalized, the EAU guidelines do provide continuously updated evidence-based recommendations and algorithms. And these are here to offer patients best known diagnostic and therapeutic options in everyday clinical decision making. And this is true for a broad spectrum of pediatric urological conditions. And when you're looking at that world map at the moment, the EAU guidelines are endorsed by 75 national societies currently. So this is a huge success of the EAU guidelines. So the EAU guidelines has built up a so-called dissemination committee that does promote the endorsement, utilization of, and the adherence to EAU guidelines. And we do that via a wide dissemination of knowledge using social media platforms and other channels. This is just how this is done at the moment. We do daily recommendations on Twitter. We use awareness day campaigns in pediatric urology, for example, the World Bedwetting Day or the Special Disability Day. We now implemented podcasts. We are using cheat sheets, which are very, very popular, especially among residents. On Instagram, we are doing quizzes and stories to help promote our guidelines and to help disseminating these guidelines. And when you're looking at the first tweet from the EAU Guidelines Office, that was posted back in 2014. In those days, you can nicely identify Professor James Endow, who pressed the button on the laptop to release the first tweet. And the diagram here very, very nicely demonstrates the impressions, how much they increased within the last 5 years. So this is really a very, very successful story. So at the end, clinical practice guidelines, what is the most important issue is that they have to be trustworthy. And trustworthy is only possible if the clinical practice guidelines are based on systematic reviews of the existing evidence. There is an importance to develop it by knowledgeable, multidisciplinary panels of experts and representatives from key affected groups from the very, very beginning on, and based on an explicit and transparent process, minimizing distortions, biases, and of course, conflict of interests. You have to consider important patient subgroups and preferences, which is definitely true for pediatric urology. You have to provide clear explanation of the logical relationships between alternative care options and health outcomes and rating level of evidence and grade of recommendations. And it's very important to have trustworthy guidelines because you need to revise and update whenever new evidence warrants modification and recommendations. So the purpose of clinical practice guidelines in pediatric urology is definitively to improve patient care. That's one of our main goals. But it must be evidence-based because we know that 90% of what is published is unreliable and unfit to trigger a change of clinical practice guidelines recommendations. Clinical practice guidelines recommendations need to be patient-focused, because clinical trial populations, they are not generalizable. So key subgroups, for example, they are typically not represented in large clinical trials. And this is especially true for pediatrics. Think of multiple comorbidities. So it's usually a huge mistake to think that published outcomes from a center of excellence are representative of practice in general. There is a huge difference in that. So the improvement of patient care needs, in addition to that, be cost effective and of course data driven. And nowadays, equitable, sustainable and transparent use of available resources to achieve a better outcome and experiences of care for every person is definitively a must. And in the future, when we are looking to future perspectives of our guidelines, real world data are becoming more and more of importance, and they need to be collected systematically because patient-related outcome measures, patient-related experience measures, and quality of life data are becoming more and more important. And that's why there is more than just one view important to come to trustworthy guidelines, because the truth does always have multiple issues. So that's very, very important to consider more than just one view. And when it comes to the EU member states, we know from various studies that still 4 out of 5 patients do not receive evidence-based care for certain conditions. And that is a huge risk because it risks poorer outcomes. It does risk unnecessary complications. It does risk unnecessary tests and costs. And of course, it risks potential harmful care. So challenging the recommendations, especially in the current pandemic situation, is another issue we have to take care of, because we are now in the COVID-19 pandemic all forced to reconsider the appropriate course of action for our patients. So therefore, within the EAU, we have built the so-called Guidelines Office Rapid Reaction Group, We re-examined all of our recommendations in the guideline and adapted it to the current COVID-19 pandemic situation. Each recommendation has to be prioritized depending on whether or not it's an emergent situation or a situation with a high priority or intermediate priority or even low priority. And this is just a snapshot from the recommendations of our pediatric urology guidelines panel that is applicable during the COVID-19 pandemic, where we try to distinguish all our recommendations, whether or not low, intermediate, high priority, or as an emergency case, or which one can be postponed. So this is the end of my lecture. I once again would like to thank all the organizers for inviting me to give you the European Association of Urology perspective in building pediatric urology guidelines, how we are taking care of these, and some of the future perspectives that we are facing, especially in the current situation with the worldwide COVID-19 pandemic. So once again, thank you very much for your attention, and I wish all of you some festive days and all the best for 2022, and let's hope and keep the fingers crossed for a better year. Thank you very much.
All over the globe. And I thank you personally because you have actually told us about the ethos around which the formulation of these guidelines lies. Actually, scoping is very important. That will be the pivot around which the entire guideline success would be there. And equitable use of various resources, the dedication with which members of the board who come together to form guidelines and put hard work, long time, again and again, is something which all without any remuneration. This is all for the love of our children. So basically, can you just begin my presentation? So I would echo your sentiments, and the difficulties and challenges of creating guidelines are far too many. In India, just like many other developing countries, we also face certain challenges which are very typical of our countries. The large population, the small doctor-patient ratio, which is only now improving, lack of uniformity in training across the country, various types of programs in which we are trying hard to bring together on the same platform, are some of the issues which we are struggling with. However, there have been incremental gains. There are boards now, there is a National Medical Commission, there is a National Board of Examination and Medical Sciences. Together, these two large bodies are addressing how we can improvise upon our training programs. So can I begin with my first slide just to show the problems that we have and how we are trying to navigate through. So this I picked up from an editorial I wrote in 2009 in our National Journal of Pediatric Surgeons. What is pediatric urology, development, eligibility of residents, and its practice. Next, please. So just to tell again, 42% of India's population is children below 18 years of age, which is a staggering number. You can know that within a few years' time, they will become adults, and it's a half the population. 1/3 of children health problems are surgical in nature. So you can imagine that we need loads of surgeons to take care of pediatric urology. Now, it is globally accepted. Now it's a recognized fact that pediatric urology and pediatric practice, any kind of healthcare to be given to children should be best done in pediatric settings, if not in a children's hospital, in a milieu, in an atmosphere where pediatric care is exclusively being offered. And there are many publications on this. And Children's Surgery, a first-class service, was a report of the Pediatric Forum of the Royal College of Surgeons in 2000. Where should pediatric surgery be performed? It has also been written by David Thomas and Leela Kapila. So there have been echoing of these sentiments. Till we have more children's hospital in India, we have to continue with what we have, but make the best out of it. Next, please. Now, in the last 24 years, there has been a constant buzz for the creation of units in respective departments exclusively for pediatric urology work. It all started way back in the mid-80s and in England, when the unit in Sheffield dedicated some of the beds to one of the consultants, Mr. Mackinnon, to carry out pediatric urology work. He was a trained pediatric surgeon, just like most of the places in England and in Europe. Pediatric surgeons are the one who have been carrying out all the load of pediatric urology work, and still they are. The immediate plan should be to create units exclusively for pediatric urology work. The fellows who are registered should be already trained, and in India we call it Master of Chirurgy. They do a 3-year course in a basic specialty. It could be pediatric surgery, and also there are adult urologists, very far and few, but they are the ones who are taking gradual interest into this. If the infrastructure of the training platform is not fully in place, then they can spend 1 or 2 years in collaboration with each other. So endourological procedures can be taught in the adult urology framework, and the reconstructive, complex reconstruction could be done in the pediatric surgery. That is the fact of life. This approach will ensure that the subspecialist cadres are developed within the existing infrastructure till the time the children's hospital increase in numbers. There are very few children's hospitals in our country. Next. Now, as we all know, circumcision, orthopexy, minor scrotal problems are routinely performed by surgeons, adult urologists, especially in non-academic settings. But it is the challenge of doing complex reconstructions, and that comes from index cases such as posterior urethral valve, prune belly syndrome, bladder exstrophy, cloaca, proximal hypospadias, ureteric malformation, and so on. These have to be done under great supervision by very trained people and in a very dedicated atmosphere. So with the positive specialists across the country, it's a no-win situation for us. So we have a large population to cater to. We should refrain from knee-jerk reaction and telling that you will not do and what you will not do. We can't have regulations penalizing people if they are offering something which unfortunately is not available at hand when the patient needs it immediately. So we have to be kind of very flexible on this. Unfortunately, it will not give the best of results, and we cannot make it kind of a rule, because if we take it lightly, then this will be a norm. Therefore, we are face these challenges, and we constantly struggle to see that we know what is the best, at the same time trying to see we can assimilate what is happening. So a balance has to be struck to achieve the best of both the worlds: delivery to the masses and training the trainers. They have to go hand in hand. So now people often say it is a market-driven training, but is it so? I mean, there are some facts. There is a general reluctance among adult program trainees to join pediatric programs. Trainees will have to spend at least 2 years in pediatric training centers to learn the surgical management of complex malformation by default and by essence. And the fact is, pediatric surgeons from time immemorial have been trained to do pediatric urological procedures. As far as India is concerned, particularly, and I'm sure it is there in most of the developing countries, the scenario was not different in Europe also, not very long ago. Skepticism of conversion from high earning areas to ones with reduced income, at least this is the impression one gets from the US model of training. Things have happened right in front of us. If you look at the last 2 decades, when the laparoscopic frame came for the most common surgery in urology, which is prostate surgery, a lot of adult urology trained who could have otherwise gone to fellowship in pediatric urology refrained from doing so. They stuck to their specialty. And before they could overcome that, robo came. So basically, we have all first-hand experience in working in such environment where we have seen adult trainees would not look at pediatric urology fellowship, where their income will fall down to 1/3 of what they would do the next morning. So obviously, the great Mr. Ransley, I was speaking to him about it, and I'm not going to go into much detail about my personal talk on that matter because he was rather taking a position on this, but he said that this mess, and this holy mess, could have been avoided if the background of those who went for pediatric urology had been pediatric surgery. Now, this is a big statement. However, since then, there have been miniaturization of equipment with better optics, and now it is possible even for adult urologists to indulge into this, but not without good training. And that's what is happening in pediatric surgery all the time. So the mandate of the teaching institution like ours, we are a tertiary care institution, All India Institute of Medical Sciences, who would practice and how to educate is our mandate. Not about who should practice, because that is regulatory. We don't have any regulatory control. So as a result, what we did 25 years ago to start societies of pediatric urology, where members can come under a banner. At that time, digital way of approach wasn't that popular, and people used to come regularly. And they were the people who were exposed to cutting-edge surgery and state-of-the-art lectures, how a particular procedure in pediatric urology would be carried out, and we provided them with an educational manual written by experts from all over the world. People like Mr. Gerhardt, Mr. Ransley, Patrick Duffy, Tom DeJong, Mr. Justin Kiley, Stuart Boyer, name the person who is master of his art. And when I'm saying pediatric urology has subspecialists. You have neurourology. You can see our logos. We have got all chapters of neurourology, nephrourology, gynecourology in children. There are a section of conditions. So we chose people and requested them to come. They were very kind. They came here, spent a few days, operated upon the cases, and our members were exposed to that state-of-the-art work. And that rubbed upon them, that raised the bar. When they went home, they found they have come back with little more training. And the educational manual, Progress in Pediatric Urology, was also available to them. So these were the societies that we started in 1998. We used to have biannual meetings. The citadel, the strong point of these workshops have been the operative procedures. It was not one of, in those times, operative procedures were being demonstrated. There were video, etc. available, easy transmissible from the theaters, but it wasn't a very popular thing at that time, but we were doing it. Now it is all over the place, and we are very happy about it. Now, so this is our Progress in Pediatric Urology, which goes to all members every year. There was a brief period of interruption because we wanted to convert it into the journal format, and now we'll have both the formats very soon. So what should be the ideal setting? It's well known. The ideal is a children's hospital, but it will take some time. The children are born, they require treatment. So in a vast country like India, it would take a while before trained pediatric urologists fill up the requirements. Till that time, the country can ill afford to term pediatric surgeons or adult urologists who are without accreditation as unqualified, because by regulation, we can't penalize them, because the children need treatment. Whoever can offer the best, he will offer. We titrate it against the caliber, etc. is another matter. That's what Dr. Professor Radmayer was talking about, that we have to, there are many countries where such regulatory processes are not there, and the children are there to be treated, and the processes are continued. Even in the US, I mean, this is something eye-opening. 2/3 of the pediatricians even are not subspecialty trained, yet 20% spend time in the subspecialty field. So it is just a matter that it is not always possible to have uniformity, but our aim should be to reach there. So, but we should also remember, hand in hand will go litigations. As the litigation issues start bleeding down the neck, as people become more aware, it is bound to happen. And therefore, we as trainers, we as institutions, as societies, we should immediately join the bandwagon in Europe also and the rest of the world, that we should make sure that we have got a full SOPs in place, which we are doing. Next, please. So as I mentioned earlier, we have two large bodies in India who look after the education and regulatory processes. One is the National Medical Commission, and the second one is the National Board of Examination in Medical Sciences. The NMC recognizes pediatric surgery training involves 40% of urology. If you look at their website, it is there. And the national board has got a specialty board for pediatric urology. And we would definitely like, and as in the board as it exists, that people who are trained, particularly in pediatric urology, they do 2 years time and train themselves, can jolly well practice. And they also become consultants as trainers. So this is what the status as of now is. And I would now ask Mehak to take the program further. Thank you very much.
Thank you, sir, for this informative talk. Our next session for the day is on biomarkers for CACUT, a game changer and not just a gimmick. This session will be chaired by Professor Meenu Bajpai, Professor Fabio Bartoli, Professor Amita Sen, and the moderator for the session will be Dr. Prabodh Goel. Professor Meenu Bajpai is a chairman and convener of the Indian Society of Pediatric Urology and Asian Society of Pediatric Urology. He is also the professor and head of Department of Pediatric Surgery at All India Institute of Medical Sciences, New Delhi. He is the executive director of National Board of Examination in Medical Sciences. Sir is also the in charge for advanced research in congenital uropathies and chronic kidney diseases. Sir is professor in charge for international cooperation, domestic and international affairs. He has also been the past president for Indian Association of Pediatric Surgeons and is the editor-in-chief for Journal of Progress in Pediatric Urology. Sir is also the editor of Journal of Indian Association of Pediatric Surgeons, and he has over 150 publications with a special interest in urology and research. Sir is well known amongst residents for his charismatic teaching skills. Professor Fabio Bartoli is the chief of pediatric surgery at University of Foggia, Italy, and is also the head of a residency program in pediatric surgery at the University of Foggia. He has vast clinical experience and has received additional training in Ireland. In addition, he has spent 5 years in Pennsylvania, United States, where he received fellowship in pediatric transplant and has also served at the University of Pittsburgh as faculty. His research interests include congenital uropathies, neonatal surgical conditions, hepatobiliary diseases, etc. He has published more than 150 papers and has presented various presentations at international conferences. Professor Amita Sen is a professor and head of Department of Pediatric Surgery at Atal Bihari Vajpayee Institute of Medical Sciences and Ram Manohar Lohia Hospital. She is an alumnus of AIIMS and has more than 50 publications in various national and international journals. The moderator for this session would be Dr. Prabodh Goel, who is an additional professor of pediatric surgery in the All India Institute of Medical Sciences, New Delhi. He is also an alumnus of this institute, an academician, ardent researcher, and a medicalist surgeon. To start the session, we now invite Professor Meenu Bajpai for his introductory remarks on the AIIMS experience of biomarkers. Over to you, sir.
Thank you, Kirtika. So in this session, we talk about biomarkers for CACUT, congenital anomalies of the kidney and urinary tract. Through serendipity, we have come across a variety of situations where we were able to pick up markers which could show us inception of injury. And based upon that, we built up an approach to management. So in the next few minutes, you will see an array of presentation from our department, from other parts of the globe, where similarly, people have been working to look at markers to guide for monitoring disease process, both before making a diagnosis, at the time of making a diagnosis, and subsequently after therapy to minimize any further injuries. So I'll just give a brief view of the topics from our department. And so it is a game changer and not a gimmick, because we saw real life scenarios. Now, our journey with biomarkers started more than 20 years ago, particularly with three conditions: the pelvic junction obstruction, the bilateral view reflux, and in posterior valve. Now, as we all know, with the advent of antenatal diagnosis in the early 80s, the diagnosis of PUJO and its management went into disarray, because what we were diagnosing antenatally very soon was found to be inoperable or not requiring operation. It was because the diagnostic tool of ultrasound, which was seen in the very antenatal period, was later found that it was a physiological phenomena, and many of these children were not fully blown into surgical intervention. So with this, it led to a dilemma of management. Parents were told that you have a fetus now who has got a problem which could be surgical. And throughout the pregnancy, parental anxiety continued. Postnatally, the child had no symptoms. There were big questions as to why should we operate upon a child who has been diagnosed far left into the spectrum. So this led to many questionable issues, because it led to a huge 25 years and 30 still continuing sort of dilemma that when to operate a PUJO. It was redefined, and people like Stephen Koff, Holmesy and Mr. Ransley and a large number of people worked upon it to pick up as to if we can make a diagnosis that there is an obstruction, there is no doubt surgery will be carried out. It was making that diagnosis which was the challenge. Because the questions were, does waiting risk renal injury? And that could be permanent. Is there a discriminatory factor which can distinguish upfront? This is a surgical baby and this is a non-surgical baby forever in his life. He will never require surgical intervention. And why function does not always recover after surgical intervention? These were the glaring questions that were being asked. Now, so we looked at what causes injury, what are the molecules which cause injury. We all know it is angiotensin 2, which leads to tubulointerstitial fibrosis, which is scarring. And it goes through a variety of pathways: proliferation of mesangial cells, transcription of collagen, production of TGF-beta-1, which is a very potent pro-sclerotic, has effects. So this is what was happening. Now, where does angiotensin 2 come from? So we looked at the pathway which produces this, and we found that it started off very early on from a protein angiotensinogen on which acts an enzyme renin, followed by angiotensin 1 and 2. That happens. So obviously, if you go far left in the natural history of a disease, renin should have been high. This was our working hypothesis. We started looking at renin. At every child, he was being followed up by just non-operative management. We started taking their samples of renin and kept them for a post hoc analysis. We never wanted to operate on the basis or any intervention on the basis of those values. We wanted to see them afterward as a post hoc analysis. And as we all know, the seat of production of renin is the juxtaglomerular apparatus. So when we looked at it, we found that those children who are still waiting for surgery, indications are not developed, they had high levels of renin and they were increasing with time. And we then published it, and we then kept on observing in small pilot studies that early markers like plasma renin activity was indicative of a start of the process of injury. So if we ignore it far too long, there will be pro-sclerotic processes, and that is when the function will never recover. So we thought that this could well be an indicator of intervention. Next, please. So we kept on collecting indisputable data, and as we progressed, and we kept on publishing them, we got very good peer reviews and in very good journals like Journal of Urology, Journal of Pediatric Urology, Kidney International, Journal of Nephrology. So we could get very good peer reviews so that we could know exactly what we are doing. Now, we also drew in a large series of cases a Kaplan-Meier curve, looking at the various other parameters which tell us about surgical intervention, which is either split renal function, glomerular filtration rate, and PRA. And we found that if you wait by the other two parameters, you have to wait for a very long time, and still some patient will be followed up. And in the process, the damage will continue. But if you take PRA, plasma renin activity, you find by that time, all the patient would have been operated. So waiting damages, and this is what we discovered. Now, look, the other condition, we tried to apply these markers for vesicular-ureteric reflux. We all know there's a global debate, for perennial debate, whether the VUR should be operated or the patient should be kept on medical management. So we looked at these markers in there also. Same strategy to look at, do a post hoc analysis, and we found after surgery, high levels of renin come down. And I am repeating, and we published it extensively. We even did interventions. So the third was the posterior ethel valve. We looked at it. The damage, which is actually scarring, is a result of tubulointerstitial fibrosis, and the entire pathway was mapped, and we could see early players like plasma renin activity, which were raised. Now, and it was an early marker. If you look at this slide, PRA rises much before the GFR starts falling. And this is very important, because if we wait that latent period time, this is that window time when the damage has started off. If we pick these markers up, these are the biomarkers that help us to pick up the disease rather early. And if we intervene at this point of time, there'll be complete reversal of pathology and there will be more further damage. So our question, why function does not recover, was we were intervening far too late. By that time, pro-fibrotic agents had actually started taking their part. And there are many more things, but as the subsequent presentation will dig deep on this. So then, in a very unusual phenomena, people often talk about creatinine nadir in posterior ethel valve. We realized that there are patients in which after doing valve ablation, the renin comes down to normal and remains normal. But there are patients where it may come down to normal for a period of time, but again starts rising. It may be 1.5 years. So unless we keep them in follow-up, we will suddenly find them one day to have damage. And we see in the second decade of life, 44% of PUV patients develop renal failure, CKD. Now, the third group was in which the fall never came to normal altogether. So these are the patients with persistently high levels of renin, which is damaging. It continues to damage them. And therefore, we thought, can we stop it? So this can be stopped by blocking the pathway. We did that also. And when we did that, we found that the function improves. This arrow, vertical arrow shows intervention, and GFR started improving. Renin came down. So the blocking the pathway. Now the blocking the pathway, we did some experimental studies first. We created a rat model of UUO, unilateral ureteric obstruction, and we created a pathology which we documented as a proof of mechanism of injury. And you can see that we saw these kidneys were contracted, and we could see the footprints of damage, which is nuclear factor kappa B. And then there were many such experiments. We used urine from patients with UTI, took that strain of E. coli, injected into the rats, documented pyelonephritis, and gave antibiotics to a group and antibiotic and ACE inhibitors to another group. You can see now that the group which received both had a very small scar as compared to the group which only received antibiotic. So all these were opening up to us. As I said, serendipity. We just looked up at something and kept our interest and dig deep, and we found that many things started unfurling. We saw many pathways, and you can just see the journey of our residents, how the research was carried out subsequently in the department. And obviously biomarker talks are from Europe and in other places also. We will hear all of them. So then we thought that why some patients who have been given surgery, equal function begin with, but as the time passes, some of them go into damage. We have offered same surgery, successful surgery, still some patient developed renal injury. There was a genetic propensity. And the first time in India, we realized that there is a polymorphism of the ACE gene, which is a rate limiting step. And in India, it is very much there. And so when we discovered, we found that those with this polymorphism would eventually go in for more injury despite your pyeloplasty. So the question that we had asked initially, why function does not recover always? There are patients, and these are the ones with underlying overtones of pathology which is going on. So what? Suppose we find a genetic reason behind it. Can we do something? Yes. These are the genetic pathways are well mapped. We can intervene to cut those pathways, and we did that. Now, if you look at it, we cut the pathways, and we found that something which was going downhill, even after surgery, blockage led to increasing GFR. This we could document it. We published it in Journal of Pediatric Urology. So it's not that the lost function cannot be retrieved. We must know what pathways are working upon it. We are surgeons. We are not supposed to do all this, but nobody does research for us. And our patients follow up with us. We see them dying. We see them going to CKD. It is pathetic. That is why pediatric surgeons and pediatric urologists, especially we who treat children, have to see them throughout their lives. We have to do our research. So nobody will do it for us. It is unfortunate, but that this is a fact. So we published all this. Thank you very much. And you will see a constellation of these presentations similar to this way forward. We are now into transcriptomics to look at, is it the gene which is causing the disease, or is the gene which is a result of disease per se? And we do serial transcriptomics to see that is mRNA regulation happening. We can cut those pathways also in order to know exactly that, yes, we can halt the disease process. So all this and more you will hear from our residents. And over to you, Kirtika, please. Thanks.
Thank you, sir. The next talk is by Dr. Sachidanand, titled From a Myth to Point of Care Tests, Our Journey with Biomarkers for CACUT Over the Last 2 Decades.
Good afternoon to all. I have nothing to declare. Talking about history and past experiences is always boring. So what I'll do is I'll walk you through our experience. So it will appear that we are connecting piece by piece like a jigsaw puzzle. Our journey started in 2002, and we have published 17 studies encompassing 1,054 children. Out of these, 2 were experimental studies on 141 rats. Over this period, we have explored all 3 major Kakut phenotypes and have studied 9 different biomarkers. Our journey started with the study of captopril renography in 2002, which was published in the Journal of Urology. And at that time, all cases of suspected pelviureteric junction obstruction were kept on conservative treatment, unless their function was less than 35%. So we all know that there is an initial vasoactive compensation because of the activation of RAS system, and the function is compensated due to that. So we hypothesized that using captopril could unmask the activated RAS system, and the pathogenesis behind this is a rise in the intrapelvic pressure can lead to constriction of the afferent arteriole, leading to a fall in the renal perfusion pressures, which is sensed by the juxtaglomerular apparatus, leading to a restoration of the filtration pressures via angiotensin II mediated constriction of the efferent arteriole. So in this study, we included 25 patients where we performed renal dynamic scans with and without captopril. And we found that we could unmask the activated RAS system in 8 patients. And this activated RAS system correlated well with the need for surgery in these cases. We say that captopril renography could identify the patients who require surgery. This study was well received by the lobby of pediatric surgeons and pediatric urologists, and it was quite motivating for us to receive positive comments from eminent scientists like Professor Saulo Klaher and Professor Holmesy. With this, we went ahead and we performed a study in 2003 where we explored the role of plasma-renin activity for primary vesico-ureteric reflux. This was published in Kidney International, and at that time, the results of international reflux study were already published, and the IRS group headed by Jean Smelly had already described that non-operative management is the norm in these cases. Surgery was regarded as equal as the medical management, and surgical intervention was only reserved for cases who had progressive scarring or a decline in the renal function. This was a step-brotherly treatment with the pediatric surgeons, and it was disregarded by the lobby of pediatric urologists across the globe. We have all gone through the editorial by Billy S. Arendt, which has highlighted the fallacies of the international reflux study. Nevertheless, we are not here for a turf war. We are custodians in time. So we hypothesize that rising plasma-renin activity can be an indicator for surgical intervention in these cases. And we found that there were significantly higher levels of plasma-renin activity in those cases which required surgery versus those who continued to be on non-operative management. So we could say that rising plasma-renin level can correlate with the need for surgery in these cases. Endpoints of non-operative management are quite inconsistent and irreversible because none of the patients have all the criteria, and we cannot wait for a spontaneous resolution in moderate to high-grade reflux. Many such children end up in chronic renal failure and end-stage renal disease. The pathogenesis behind this is that scarring leads to formation of atubular glomeruli, which are seats of independent renin hyperproduction. That leads to higher levels of angiotensin II, leading to progressive scarring. So scarring leads to progressive scarring. Here we can see that atubular glomeruli are there, and there is hyperstaining of renin in these regions. Not only this, scarring can also lead to renin as well as non-renin driven hypertension, which increases the morbidity of these cases. With the background of activated RAS system, we then explored the role of polymorphisms in angiotensin converting enzyme gene. It was an intron 16 region of the ACE gene that showed an insertion deletion polymorphism. The study was published in the Journal of Urology, and we could find that DD genotype has highest levels of ACE enzyme versus ID genotype versus II genotype. So the genotypic distribution was nearly similar in patients versus controls. However, in children with Charcot, the presence of D allele correlated well with progressive scarring. So we could conclude in this study that D allele is an independent risk factor for children with Charcot who have scarring. With this in mind, our next step was to study the blockade of RAS pathway, but at that time, there were no clinical trials or clinical studies that could suggest the safety of ACE inhibitors in children. So performing an experimental study was a worthy alternative. We included 45 adult female rats where E. coli suspension was injected into their kidneys, which was delivered by a modified lumbotomy approach. And scarring was compared in 3 groups, one where only antibiotics were given, one where captopril was added, and the third where losartan was added. We find that eventually scarring was seen in all of the rats. However, the temporal patterns of histopathological damage differed among the 3 subgroups. The initial inflammation, tubular damage, and abscesses were nearly similar among the 3 subgroups. However, the severity of scarring differed among the groups, and group A had most severe scarring as compared to the 2 groups where renoprotective drugs were given. So we could say that changes at 48 hours and 7 days are actually because of acute inflammation and are not altered by giving ACE inhibitors or angiotensin receptor blockers. There is a definite role of renin-angiotensin system in the propagation of renal scars, and pre-treatment with ACE inhibitors or ARBs could reduce the intensity of scarring. With the background of role of PRA in vesico-ureteric reflux, we went ahead and studied another Charcot phenotype, which was posterior urethral valve. The study was published in the Journal of Urology, and we could find that there is a temporal relationship between the rise in plasma renin activity levels and the decline in GFR. So there was a latent period where we could add angiotensin receptor blockers or ACE inhibitors to reverse the renal injury. With this, we went ahead with exploring the role of plasma renin activity in Puget type hydronephrosis as a prognostic marker, and we included 90 children, and we found that there was a fall in the split renal function and the glomerular filtration rate in the cases which were operated, but it recovered significantly after surgery. Plasma renin activity levels also showed a similar trend. There was a rise till the time of surgery, but it declined significantly after surgery. On the other hand, children who were kept on non-operative management showed a progressive rise in plasma renin activity levels and a progressive decline in the renal function. The temporal relationship was nearly similar what we found in posterior urethral valve, that the rise in plasma renin activity levels was much before the fall in split renal function or glomerular filtration rate. Also, we found that the final levels of plasma renin activity were much lower in cases who had undergone surgery versus those who were continued on non-operative management. So there are definite fallacies in the current diagnostic criteria of pelviureteric junction obstruction, because there is no single test that has enough discriminatory ability in diagnosing pelviureteric junction obstruction. And there are innate problems in the interpretation of RDS curves despite newer parameters such as renal cortical transit time. In addition, everyone says that the follow-up in cases who are continued on non-operative management is mandatory, but there is no consensus as on how long and how frequent this follow-up should be. So we could say that rising plasma renin activity levels are an indicator of obstructive stress, and the chronicity of rise in plasma renin activity has a bearing on the extent of recovery. And PRA measurement is imperative in cases of non-operative management. Like the international reflux study, we also followed our cases which were continued on non-operative management, and we analyzed the midterm results. The study was published in the Journal of Pediatric Urology, and we could find that the levels of plasma renin activity in children who were operated, the final levels were much lower as compared to those who were continued on non-operative management. So what is the cause of this continuous damage of kidneys in cases who are continued on non-operative management? We are all aware with the theory by Ransley and Risden that an infection is required for causing renal tract damage. But there is another phenomena that takes in. This is the water hammer effect, that sterile UTIs and subclinical UTIs can also cause upper tract damage. This is because of the higher bladder pressures that are transmitted to the upper tracts, leading to scarring. In 2011, we conducted our first clinical study, which focused on the activation of RAS pathway and blockade of RAS pathway at the same time. This was the first study of its kind, and we measured plasma renin activity levels along with microalbuminuria in cases of vesicoureteric reflux, along with the routine investigations. Children who had microalbuminuria were given ACE inhibitors, and we measured the levels of biomarkers in all of them. As microalbumin is an indicator of early renal damage, we hypothesized that early RAS blockade can actually lead to a recovery in the function. And we found that there was a definite fall in the microalbumin levels as well as the plasma renin activity levels after surgery. But this was short-lived, and there was a gradual rise after this. In a subset of patients, we gave ACE inhibitors, and we found that there is a definite recovery and the microalbumin levels came back to normal. There was a transient rise in the plasma renin activity because of the negative feedback. So we could say that we can divide the temporal patterns of children with vesicoureteric reflux after surgery into 4 phases. And the 4th phase was most critical, where we introduced ACE inhibitors, and we found that there is a recovery in the renal function. We had also conducted an experimental study of a rat model where we created pelviureteric junction obstruction, and it was quite similar to that of vesicoureteric reflux. We studied the morphometric parameters and the pathological grades of injury. We found that in the subgroups where renoprotective drugs were given, they had a final renal height which was significantly higher as compared to the other rats, as well as the cortical thickness was more, the pelvic volumes were significantly less, and the pathological changes were less severe in these rats. With ample data on biomarkers such as plasma renin activity and microalbumin, we went ahead and we explored newer biomarkers such as TGF-beta1, TNF-alpha, and IL-6. We found that there is a progressive decline in the levels of TGF-beta1 in one of the subgroup, while in the second subgroup, it showed a rise in the TGF-beta1 levels after an initial fall. This is the subset where we could introduce ACE inhibitors and we could retard the pace of renal injury. And the findings were similar for TNF-alpha and IL-6. The pathophysiological basis behind this is induction of inflammatory biomarkers and cytokines by angiotensin II mediated action on the angiotensin type 2 receptor. Angiotensin type 1 receptor is responsible for vasoconstriction and type 2 for its pro-apoptotic effects. Then with the ample data on blockade of RAS pathway, we went ahead and we performed 2 studies in 2013 where we explored the role of preemptive blockade of RAS pathway, that is immediately after surgery. And we could find that there was a recovery in the renal function as well as a fall in the plasma renin activity in cases where scarring had not happened. And we could retard the pace of renal injury in these cases. In cases who were having posterior urethral valve, we found that if we introduced ACE inhibitors preemptively, then the final GFR and the final plasma renin activity levels were significantly different when we introduced it later. So in this subset also, we could retard the pace of renal damage. The next phenotype was quite interesting, and it is a headache for all pediatric urologists: bilateral pelviureteric junction obstruction. Before conducting this study, we had 2 questions in mind. One, whether plasma renin activity levels could correlate with the extent of histopathological damage in these cases. And second, whether PRA levels could discriminate between actual obstruction versus compensatory hydronephrosis. And we found that PRA levels correlate well with the extent of histopathological damage as opposed to split renal function and SFU grade. Also, the levels of plasma renin activity fell significantly in cases who had compensatory hydronephrosis at 6 weeks. On the other hand, the levels of plasma renin activity were still higher at 6 weeks and plateaued in cases which had actual obstruction. One of our recent studies also explored the role of plasma renin activity in children who had received injection deflux treatment. We included 63 patients with different grades of reflux, and we found that in low-grade reflux, plasma renin activity levels correlate well with reflux resolution, while in high-grade reflux, the plasma renin activity levels correlate well with the need for further deflux injection and the incidence of breakthrough urinary tract infections. We now came to the next leg of our studies, and everyone is aware that early prognostication is imperative in cases of posterior urethral valve. So we did a cord blood PRA assessment in cases which had antenatal hydronephrosis, and we found that the levels of PRA were significantly higher in cases which had PUV versus non-PUV. When we followed these cases of PUV, we found that there was a significant decline in the levels of PRA after valve incision. Also, PRA levels predicted the GFR at 6 months. The babies which had higher PRA levels at the outset had a lower GFR at 6 months versus those who had a GFR of more than 60. Recently, we have conducted 2 studies where we have explored the role of novel biomarkers, including trefoil family factor 1 and 3, neutrophil gelatinase associated lipocalin. And we have discovered that all of these biomarkers are raised in patients having CACUT versus controls. The levels are highest in PUV, followed by VUR, followed by PUJO. And these levels correlate well with progressive deterioration in renal function. TFF3 on a ROC curve has maximum area under the curve and is the best predictor of prognostic damage. We also studied the influence of genetic polymorphisms, and we found that presence of D allele of ACE gene and 82R A allele of 82R gene showed a correlation with higher levels of TFF3 and higher extent of histopathological damage. We also found that children who are having homozygous varieties of both DD and AA alleles, they have highest TFF3 levels as compared to those where there is either of them. The basis behind this is renal programming. And as per the traditional teaching, this programming occurs in the first 36 months of life. But recently, according to one of our studies, we have found that this programming occurs in the first 1,000 days of life. It includes 9 months of intrapartum life and first 2 years of postnatal period. And not only the genetic polymorphisms, postnatal insults in the form of UTI drugs can also cause significant damage and can lead to a negative renal programming. When we talk about renal programming and we don't discuss nuclear factor kappa B, it is not justified. So, nuclear factor kappa B is actually a promoter stimulator of all of the pro-inflammatory cytokines that plays a significant role along with angiotensin II, or we can say the central role along with angiotensin II in mediating fibrosis in cases of CACUT. To summarize, we have seen that biomarkers have a great potential in diagnosis, prognostication, choice of therapy, and monitoring the response to therapy. Our next studies are focused on artificial intelligence and machine learning. We have built a 392 panel of these biomarkers along with the inputs from IIT Delhi, and we are exploring these biomarkers. Secondly, our study is focused on transcriptomic analysis. As Sir has said, that we have identified 19 or 20 regions where we could target and reverse renal injury. This slide was introduced lately by us because we are quite frequently bombarded by this question, how to choose the ideal panel of biomarkers. Well, we should consider certain factors for this. First, specific roles. We should not include all the biomarkers that are pertinent to diagnosis or either prognosis. It should be a mix and match of both. Site of origin. So we should not include all the biomarkers from glomerular origin or PCT origin. It should be again a mix and match. Mutual compensation is very important because if we include all urinary biomarkers in a case of bladder outlet obstruction or upper tract obstruction, then the yield of biomarker is going to decrease and we would not get positive results. So as you have seen that we have always included plasma renin activity along with the urinary biomarker like NGAL or TFF. We were recently interrogated by one of the senior pediatric urologists regarding the cost factor. So cost is very important in resource challenged nation. And at that time, we had no answer to this. But now we have interrogated around 60 distributors across the globe. And we can say that the cost can fluctuate between 360 rupees to 14,000 Indian rupees. And this solely depends on the quality of the antigen in the ELISA kit. The sensitivity and specificity are other parameters that should be kept in mind. And the last question is how many? Well, this is quite a tough factor to consider, but we have always got away with including 4 biomarkers, but the ideal number is yet to be explored. I thank Professor Bajpai for mentoring us throughout these years. Thanks to the Department of Pediatric Surgery, all teachers, seniors, colleagues, PhD students, and scientists who have contributed their works. Thanks to the allied departments. Thank you.
Oh, hello. Thank you, Dr. Anand. That was a very comprehensive coverage of the subject. And if we are going to do your question answers now, then is there time or shall we go on to the next talk, Dr. Bajpai?
Definitely, if there is any question, do we have a chat box here where we can see some 1 or 2 questions can be taken up for the audience in general? Well, good afternoon, Professor Bartoli. Can you hear us? We can't. Can you unmute your audio, please?
Okay.
Yeah,
we
can hear you. Yes, we can hear you very well. Thank you.
Thank you very much for inviting me to this very interesting and important meeting on biomarkers on urology. And to be honest, I'm really impressed from the experience that AIMS has developed in the last 20 years on this field. And let me congratulate. I found very nice your studies and underline the role of angiotensin system in the progression of nephropathy secondary to Charcot. So what I can say, I think you are in the right way, and also the future development of proteomics and a more limited panel set of biomarkers will be the way to best care for these children. So how I can help now? Should I introduce presentation?
Yes, thank you very much, Professor Bartoli, for your kind words. And thank you again for joining in the middle of festivities in Europe. You have joined us for academic activity.
Can I say bye to Professor Mino Bajpai? I had the pleasure to know him when I visited AIMS in 2001. I don't know if you remember.
Yes, very much. How can we forget you? It's such a pleasure to see you again.
Is Devendra retired?
No, he has retired, but he is still active. He is doing something or the other. You can't expect him to be quiet.
Say bye with all my heart to him.
Definitely, definitely.
We will now proceed to the guest presenters.
Is there a Dr. Ramesh Babu wants to say something? We can invite him at the end of the session. Thank you.
Thank you, sir. We will now be starting with the guest presenters of this session, who will be talking about their individual experiences with various biomarkers. Each presentation is of 8 minutes and will be followed by a brief Q&A over 2 minutes by the panel. The delegates are free to type their queries in the chat box for further discussion. A hands-on endo-training session is available in front of the auditorium adjacent to the central lawn. The residents and trainees can have a hands-on experience of the endo-trainer. The coordinator for the endo-trainer is Dr. Shishir. The first presenter of this session is Dr. Pratibha Nayak for her talk on the utility of urinary biomarkers, NGAL and KIM1, for diagnosing the presence of renal scar in children with vesicoureteral reflux, a cross-sectional study. She is a JIPMA alumni and has a keen clinical and research interest in biomarkers in Kakut. Over to you, ma'am.
Good afternoon, one and all. I'm Dr. Pratibha Binayak. I'll be presenting utility of urinary biomarkers, NGAL and KIM1, in predicting the presence of renal scar in children with vesicoureteric reflux, a prospective cross-sectional study. This study was conducted in the Department of Pediatric Surgery in collaboration with Nuclear Medicine and Biochemistry in JIPMA, Puducherry. Vesicoureteric reflux is one of the most common congenital urinary tract infections seen in children with a prevalence of approximately 1.6%. Vesicoureteric reflux predisposes to pyelonephritis, which can lead on to focal ischemia, interstitial damage, fibrosis, and renal parenchymal scarring. The long-term complications including hypertension, proteinuria, and chronic kidney disease. Hence, early detection and timely intervention is essential. DMSA, which is dimercaptosuccinic acid renal scintigraphy, is the gold standard with high sensitivity for renal scarring in predicting renal scar in vesicoureteric reflux patient. But the ionizing radiation, invasiveness, and expensive nature limits its utilization on a regular basis. Hence, the urinary biomarkers, that is, the biological substances that can be accurately and reproducibly measured as an indicator of normal or pathogenic states or conditions, can be used. We have used NGAL and KIM1. NGAL, which is neutrophil gelatinase-associated lipocalin, belongs to the lipocalin family, and it is secreted from the thick ascending limb of loop of Henle and the collecting ducts of the kidney. KIM1, which is a signaling molecule, is secreted from the proximal tubule and during tubulointerstitial damage. Her aim was to explore the possibility of using NGAL and KIM1 as urinary biomarker to assess the presence of renal scar in children with vesicoureteric reflux. It was a cross-sectional study conducted from December 2017 to October 2019. Children less than 16 years with VUR were enrolled, and statistical analysis SPSS 19 was used, and p-value less than 0.05 was taken as significant. The study population was total of 107 patients were enrolled, of which concurrent PUGO, duplex, ureterocele, renal parenchymal disease, EGFR less than 50%, and EGFR less than 30 ml per minute per meter square patients were excluded. So the final study population was 94. These final study population were divided into low and high grade VUR, that is low, grade 1 and 2, and high grade were 3, 4, and 5. And a DMSA scan was done on this patient, and the scarring was graded accordingly. That is 0, no scar, 1, 1 scar, and 2, 2 scar. And in case of multiple scar, that's more than 2, it was taken as 3. In case of bilateral scarring, it was cumulated. 15 ml spot urine sample was also taken on the same day, and it was stored at -80 degrees Celsius. And using commercially available ELISA kits, urinary biomarker NGAL and KIM1 were evaluated, and then it was standardized with urinary creatinine. IEC approval and consent were taken. Coming to results, we had 75 girls and 19 boys. We had 39 unilateral patients and 55 bilateral patients. And majority of our study population was between 1 and 5 years of age, which was 52%, that is 49 patients. We took the parameters, that is age, height, weight, serum creatinine, urinary creatinine, EGFR, serum urea, and we compared between patients with scar and without scarring. And the urinary biomarkers, that is NGAL, KIM1, and also they were standardized with urinary creatinine, and were evaluated or calculated, and it was compared between scar and no scar patients. Here we can see that in case of NGAL, in scar patients, it was increased and it was clinically significant. But when it was standardized, even though it was increased in patients with renal scarring, it was not significant. Kimber did not show significance or the correlation. This is a graphical representation of the same. Coming to urinary biomarkers with respect to severity of the scar, that is 1, 2, and multiple scar. Here again, we can see that NGAL was comparable, that is, it was raised and it was clinically significant. But when it was standardized, even though it was comparable, it was not clinically significant. We divided the study the cohort population into unilateral and bilateral patients, and we compared between scar and no scar patient. Here in bilateral VOR, we found that urinary NGAL by creatinine was comparable and also significant. And again, the unilateral and bilateral patients were correlated with respect to low grade and high grade reflex. And in case of bilateral reflex, we saw that urinary NGAL by creatinine was comparable and significant. We plotted all the biomarkers on ROC curve analysis, and this cohort, we could see that NGAL was having area under the curve of 0.76 with sensitivity and specificity of 71%, cutoff value of 0.9, and it was clinically significant. But urinary NGAL by when it was standardized by creatinine, the area under curve was 0.6 with sensitivity specificity of 60 and 61% respectively, and cutoff of 0.045, and it was not significant. So this is the ROC curve, the yellow line showing the reference and the green showing NGAL. This is NGAL by urinary creatinine, KIM1, and KIM1 by urinary creatinine in our study was showing a negative correlation. NGAL showing the larger area under the curve. Coming to discussion, Ishino et al., Pamakis et al., and Devarajan et al., everyone studied the NGAL correlation of NGAL with vesicoaortic reflex grading. In Ishino et al., they found there was no correlation of urinary NGAL with regards to reflex grading, but they was significantly higher with respect to scarring patient. It was significantly increased in patients with scarring. Likewise, in Pamakis et al. And Devraj et al. Also, they found that urinary NGAL by creatinine correlated with increase in scar patient. Our study, urinary NGAL alone was higher in scar patient and was significant. When it was standardized, it was higher in renal scar patients, but it was not significant when it was standardized by urinary creatinine. And with regards to severity of renal scar, urinary NGAL by creatinine was comparable, but it was not significant. We actually had statistically significant difference in age, height, and weight in the scarring and no scarring group in our study. Majority of our study patients were 1 to 5 years of age. It is seen that in infants, that is less than 1 year, they excrete high NGAL and renal cell proliferation is going on at that stage. And small kidneys which secrete less NGAL were not excluded in our study. These are the different studies, that is Ishino et al., Pamakis, and our study showing the cutoff value, sensitivity, specificity for urinary NGAL by creatinine. Urinary KIM1 and with respect to renal scarring VOR. Toker et al., the study showed that KIM1 had a positive correlation with VOR grade. But in our study, we found that there was a negative correlation of KIM1 by urinary creatinine to renal scar. Coming to Pamakis et al., our study and Pamakis et al. Both showed that the KIM1 by urinary creatinine was not correlating with renal scar. Limitation of our study was it was a single center study. The sample size was small and 2 groups of VOR, they were not age matched. And we did not exclude patients with congenital small scarred kidney. Take home messages. Yes, imaging study, that is DMSA, is the first line of investigation for diagnosis and follow-up. But in a resource challenged country like us, addition of biomarker can help in early diagnosis of renal scar and which will further facilitate the follow-up of the patient. So urinary NGAL can serve as has a potential to serve as a good predictor of renal scar in VOR, but we have to back it up with a large multicentric study and also a significant cohort. These are my references. Thank you so much. Thank you, sir.
Yeah, either ask through the chat box or direct. Well, the first question I'll take. Doctor, please let
Yes,
me
ma'am.
know that after you completed your study and
Yes,
you
ma'am.
discovered that this is going to be the prognostication, did
Yes,
it
ma'am.
in any way change your management, actual management of your clinical patients after the study?
Yes, ma'am. After the study, actually, we were using the urinary biomarker when the patient were coming for follow-up. We did not take the patient, all of us, directly in the follow for DMSA. We did the urinary biomarker, saw if there was a rise in the urinary NGAL value, and then we were subjecting them to DMSA scan, ma'am.
So that's a significant change in the line of management.
Yes, ma'am.
Are there any other further questions from anybody? Audience, chairpersons?
I was underlined that very nice study, well
Thank you,
done,
sir.
in my opinion, and it is the usual problem that we have when we measure urinary biomarkers. You found quite to be significant in bilateral reflux, even if normalized
Yes.
to creatinine, right? The markers.
Yes, sir.
It's the problem that often the unilateral disease, we have the healthy kidney that, produce urine normal, which is affect the concentration of urinary biomarkers. We found a very important difference when we operate PUJ obstruction. And we had a stent after surgery. We can monitor exactly the same size from the urinary biomarkers, and we found that these biomarkers were quite reliable. So I don't know how to solve this problem, but this is the problem that we have when we go to manage urinary biomarkers. That's congratulations, very nice study.
Thank you, sir. Thank you.
If there are no further questions, can we proceed for the next presentation by Dr. Matthew Pessalon? Prenatal biomarkers in case of CACUT, are they really useful? Over to Dr. Matthew.
Good morning, ladies and gentlemen. Can you see my screen and can you hear me clearly? So I'm really happy to present this talk about prenatal biomarkers in case of CACUT. Are they really useful? It's a multidisciplinary study from my hospital in Paris in collaboration with Indiana University and Riley Hospital in Indianapolis, USA. And I have no disclosure. Why do we perform amniotic biochemistry analysis? Is to fulfill two goals. One is to evaluate the prenatal renal function, and the other one is to look for other malformation. When do we perform this kind of analysis? In case of unilateral ureteral dilation, bilateral hydronephrosis, and nephropathies. And we have three parameters that we can use: amniotic fluid volume, fetal blood microglobulin, and fetal urine biochemistry. What it's not relevant to do to perform during pregnancy, we can't find any amniotic fluid biomarkers, we can't do any renal biopsy, and there is no relevant values for fetal blood creatinine. Why can we prescribe this kind of analysis? If we have an idea of pregnancy termination, if you would like to do an in utero management in case of preterm delivery, and to look at and to be more focused of postnatal management. The final objective in our study and in our team is to choose the 2-year renal function evaluated by the Rivers-Schwartz equation for GFR. We divided this talk between 3 parts, one about nephropathies and 2 about CACUT, in case we use fetal blood or fetal urine. In case of nephropathies like bilateral renal agenesis, multicystic renal dysplasia, polycystic renal disease, and increased renal achronogenicity, we find that fetal blood beta microglobulin was the most significant parameter. If you look at the review of the literature for the last 20 years, beta-2 microglobulin is really well known to be a significant parameters to predict end-stage renal disease in children. And in our experience with 239 bilateral nephropathies without any associated malformation, beta-2 microglobulin in the fetal blood and amniotic fluid volume were really interesting. Beta-2 microglobulin is an excellent marker for renal failure in case of renal agenesis and bilateral multicystic renal disease, even if the prognosis is already established by renal prenatal ultrasound. In case of renal hyperplasia, beta-2 microglobulin is an excellent marker for renal failure too. And in case of increased renal echogenicity, a variation in amniotic fluid volume is predictive of renal failure. But 10% of fetus with normal renal function has an oligoamnios, and abnormal values of beta-2 microglobulin is always a marker for renal failure. If we look for ACE inhibitors exposure, we can lead to nephropathies. The combination of amniotic fluid volume and fetal blood beta-2 microglobulin was predictive of postnatal renal function, bad function. Now, if we focus on CACUTs, what we can use for in case of lower urinary tract obstruction, fetal blood and or fetal urine, in case of PUV, UPGO, primary obstructive megaureter, first trimester megacystis, megalorrhea, or any other syndromic malformation. The first parameters where we can look for is amniotic fluid volume, and which is really interesting is 23% of normal amniotic fluid have renal failure at the end of a pregnancy. So if amniotic fluid volume is not really significant, we can use fetal serum beta-2 microglobulin. We look at 3 markers in the fetal blood, and we conclude that the beta-2 microglobulin was the best marker in cases of congenital kidney urinary tract malformation. Fetal blood beta-2 microglobulin over 6 is always predictive of renal failure. And there is a gray area between 5 and 6 milligram per liter, which lead in our team to a single sample to look for kinetics of beta-2 microglobulin in fetal blood. So to summarize, for bilateral and severe CACUTs, fetal blood beta-2 microglobulin is really interesting over 5 milligram per liter and leading to renal failure in close to 100%. And it's associated with postnatal serum creatinine. If we compare amniotic fluid versus beta-2 microglobulin, the amniotic fluid can be normal in 23%, or whereas the child will have a postnatal renal failure. So in our team, we think that beta-2 microglobulin is better in fetal blood. But some errors occurs in case of contamination by maternal blood or by amniotic fluid. And we use a purity test to prove that the fetal blood beta-2 microglobulin is well established. In case of discrete measure, you have to do a second sample after 15 days to look for kinetics of fetal blood beta-2 microglobulin. The last part will be focused more about fetal urine, but we can offer to any patient who have a urethral or hydronephrosis. And we offer that for in case of megacystis. Even there is a lack of maturation at the first trimester, and Adenauer et al. In 2013 give us a new threshold for calcium, sodium, and beta-2 microglobulin. You can puncture the bladder, the pelvis, or the ureter. And 7 parameters are analyzed: total protein, beta-2 microglobulin, sodium and chloride are the same dosage, glucose, calcium, and phosphor. In case of some errors can occur if you puncture in the ureter in case of urinoma, urinary cyst, cloaca, and non-functional kidney. In this case, you have to analyze digestive enzyme to give less errors. Normal values have been established by our lab, and in case of beta-2 microglobulin over 5 and sodium over 60, it can lead to renal failure. You can look at the screen showing that urine, fetal urine beta-2 microglobulin over 5 give 90% cases of renal failure. Sodium over 70 millimole per liter give 96% of renal failure. And in case of normal amniotic fluid, some of them have renal failure too. That's why we don't use too much amniotic fluid volume for prenatal screening. So fetal urine is a good marker for postnatal renal function at 2 years. And even for long-term outcomes after 10 years, you can look at fetal urine over 5, lead always to end-stage renal failure for teenagers. If you look at the total of parameters that we focus on, beta-2 microglobulin is the most significant and amniotic fluid volume is the less significant. And we use now a new multiparametric score that we published 2 years ago. Beta-2 microglobulin in the fetal urine time chloride divided by 10 is really a good model for postnatal renal failure at 10 years. So we use all 3 together parameters, fetal blood, fetal urine, and amniotic fluid volume in case of CACUS, and we look for, and we screen for digestive malformation too. We do that because close to 20% of CACUT and nephropathies have over malformation, and more especially in case of female fetus. They are led by digestive malformation, cloaca, and anorectal malformation. And some patients have chromosomic abnormalities too. So to conclude, are prenatal markers useful for CACUT? The answer is yes, with the help of prenatal renal ultrasound. The take-home messages are fetal blood and fetal urine beta-2 microglobulin are more significant parameters in case of renal hyperplasia and CACUT. So fetal biomarkers may help to confirm the bad prognosis established by prenatal ultrasound. Fetal markers is a keystone in our experience in parental counseling with prenatal ultrasound, but long-term outcomes need to be our main objective. I would like to thank you all my team who work with me on a daily basis, from prenatal diagnosis to pediatric urology, nephrology, surgery, anesthesia, ICU, and the team from Raleigh in the US. Thank you.
Thank you. I would now request our co-chairperson, Professor Fabio Bartoli, if you would like to ask Dr. Matthew Pessilon some specific thing about his talk.
Dr. Pessilon, very nice lecture. And let me share, I agree, we found also that beta-2 microglobulin is a nice marker to progressive nephropathy. And it's interesting also, I would like to know more about the formula modified with levels of chloride. How you get that? And the other question I'm asking, because the compliance for parents to have puncture amniotic fluids for markers or fetal blood is quite high in our country. I wanted to know if you have any obstetrical complication or following this puncture, you know? And because he's quite a concern about this.
Thank you, sir, for your question. You're right. The new score that we use to modelize the long-term outcomes is really interesting. So we look at the 100 patients who are between now 10 and 15 years with renal failure and no renal failure. And we figure out that the best score is to multiply the chlor with the fetal urine chlor and the fetal urine beta-2 microglobulin to assess a bad or good renal function when children are teenagers. And so it's just only 100 patients, but as you may know, it's always hard to follow up all these patients, and I will say normal renal function patients who are a loss of follow-up at teenagers because they don't have any disease. So, but we think really interesting this new score that we use now, and we use more specifically when we counsel patients and parents during the pregnancy. And it's the second part of your question about compliance for doing any amniotic fluid, fetal urine, and fetal blood sample during pregnancy. I think it's a question of culture, and the French society is really focused of prenatal diagnosis, and parents push us up to be more accurate, to have a more good accuracy for prenatal diagnosis. And if we look at complication after samples, it's less than 0.2%. The most difficult part is when we insert a stent in case of vesicular amniotic fluid or in utero management for PUV section. The preterm delivery and unfortunately the case of death during pregnancy is quite high. But if it's just a question of samples, the complications are really low.
Thank you very much.
Thank you. There's a question in the chat box, I believe, if it can be asked. For this talk, there's a question in the chat box. No. Okay, there's no further questions. Thank you very much, Dr. Matthew Pessilon. And now we invite Dr. Ankur Mandelia to deliver his talk.
Yeah, good evening, everyone. And at the outset, I will like to thank Professor Bajpai and the entire organizing team for inviting me. And I'll just share my screen. Can you see my screen, please?
Yes.
Yeah. The topic of the study was the role of urinary TGF-beta, TNF-alpha, and IL-6 for monitoring therapy in posterior valves. This was a MCH dissertation done between the years 2010 and 2012 with Professor Bajpai as the chief guide. We published this study later in 2013 in Pediatric Nephrology Journal. It has been cited various times after that. But the citation which is really significant is the citation in the Campbell Welch Urology 12th edition in the chapter Posterior Valves, where they cite our article, and they and I quote that they say the administering an angiotensin converting enzyme inhibitor shows therapeutic potential in experimental studies by reducing fibrosis. They have quoted various studies for that. And this seems to reduce expression of biomarkers such as TGF-beta, tumor necrosis factor alpha, suggesting a potential role in selected children with posterior valves. They further summarize the role of biomarkers in posterior valves. And I would like to highlight that they have summarized that there is an upregulation of angiotensin 2, and the AC2 gene is expressed significantly more, and the angiotensin receptor gene significantly less. So, now from experimental studies, this has moved to standard textbooks like Campbell's Urology, and what they are highlighting is the role of angiotensin 2, which, in addition to its hemodynamic effects, also causes pro-fibrogenic and pro-inflammatory actions through various cytokines and chemokines, which causes increased extracellular matrix production and reduced degradation. And ultimately, this results in renal fibrosis and progressive renal damage. The utility of ACE inhibitors in slowing progression of various glomerular diseases like focal glomerulosclerosis and diabetic nephropathy is well established in adults and is routinely used. But the effect on regulating the RAS pathway and retarding renal damage in posterior valves had not been studied when we planned this study. So the aim of our study was to evaluate the urinary cytokines TGF-beta1, TNF-alpha, interleukin-6, and microalbuminuria before and after ablation of posterior valves, and to examine the effect of early induction of ACE inhibition on renal recovery. This was a prospective cohort study over a 2-year period, and we included 30 patients with diagnosis of posterior valves who underwent primary valve ablation at AIIMS during the study period. Children operated elsewhere were excluded. Also, children undergoing diversion procedures were excluded from the study. The controls were age-matched boys without urinary tract disease or concurrent acute illness. Various study variables were recorded at different points of time. Urine samples were collected by a clean catch method and stored at -70°C until they were ready for use. The urinary cytokines were measured by commercially available ELISA kit, and they were measured before valve ablation and 1, 3, 6, and 12 months after the valve ablation. The patient cohort was divided at 6 months of age after an interim analysis. Group 1 included 16 patients with declining TGF-beta till 6 months post-ablation. This group patients were followed up and no further intervention was required. In group 2 patients, it included 14 children who had a rising or plateauing TGF-beta levels till 6 months post-ablation. In this group, ACE inhibitor therapy was started with enalapril at a dose of 0.2 milligrams per kg per day, and it was continued for 6 months post-ablation. So among the 30 patients, the median age at valve ablation was 5 months, and it was not different between the two groups. Around 43% patients had an antenatal diagnosis, out of which 16% patients had maternal oligohydramnios, and this was more, the numbers were more in the group 2 with worse renal parameters. Also, hypertension, bilateral hydronephrosis, reflux, and scars were more common in the second group with the worse renal parameters. So the first urinary cytokine which we studied was the urinary TGF-beta1. In group 1, the preoperative levels were significantly higher than controls, but following valve ablation in this subgroup, the urinary TGF-beta1 had a progressive decline till 12 months after valve ablation, and the level was slightly higher than the control group at that point. In group 2, the preoperative levels were significantly higher and much higher than the group 1 levels also. After the valve ablation, it showed a transient reduction. However, till 6 months post-ablation, it continued to rise when the enalapril therapy was instituted, and following which there was a significant fall in the TGF-beta levels, but it was still significantly higher than the control group. The urinary TNF-alpha levels also were significantly higher than the controls, and in group 1, they progressively reduced following valve ablation till 12 months after surgery. In group 2, after an initial fall, the TNF-alpha levels progressively increased till 6 months, at which point the enalapril therapy was instituted. However, for urinary TNF-alpha, it did not show any change following enalapril therapy. The microalbuminuria also was significantly higher than the control group in both group 1 and group 2. In group 1, it progressively reduced following valve ablation. However, in group 2, it progressively increased after an initial fall till 6 months after surgery, at which point enalapril therapy was given, and it again resulted in a reduction in the urinary microalbumin levels. If we see the progression of variables in both group 1 and group 2, the group 1 had slight improvement in the split renal function and GFR following surgery, and the nadir serum creatinine at 12 months of age was 0.6. In group 2, again the split renal function and GFR improved, and the nadir serum creatinine was 0.7 at 12 months following surgery. We also studied both the groups in terms of presence of scars and the presence of reflux. In the group with scars, the urinary cytokines TGF-beta, TNF-alpha, and the urine microalbumin levels were significantly higher than patients with no scars. And when we compared patients with reflux versus patients without reflux, the urinary cytokine levels were higher, but the difference did not reach a statistical significance. The limitations of our study was that there was lack of controls and randomization in group 2, as we gave the enalapril therapy to all the patients who had a progressive increase in the cytokine levels. So the lack of controls and randomization in group 2 is one of the limitations. Also, as the median age at valve ablation was 5 months and most of the patients were infants, some renal recovery in both the groups can be attributed to the tubular maturation which occurs in the first 2 years of life. Also, we had a very small cohort of patients, 16 and 14 respectively in both the groups, and follow-up data was limited to 12 months post-ablation. So summarizing, we found significantly higher urinary TGF-beta, TNF-alpha, and microalbumin levels in posterior urethral valve patients compared to controls. There was a gradual downregulation of RAS system following removal of the bladder outlet obstruction in one of the subgroups. However, in the other subgroup, there was ongoing renal damage, and the RAS was upregulated even after valve ablation. However, after institution of AC inhibitor therapy, there was a significant reduction in the urinary cytokines in this subgroup of patients. In the patients with renal scars, again, the urinary cytokines TGF-beta, TNF-alpha, and microalbumin was significantly higher, indicating an active tubulointerstitial fibrogenesis and RAS activation in this group of patients. So concluding, this study provides evidence that there is ongoing renal damage in subgroup of patients with posterior urethral valve, even after valve ablation. Urinary TGF-beta, TNF-alpha, and microalbumin are markers that reflect the beginning of RAS activation and can detect early renal damage. And ACE inhibitors may have a role in retarding the pace of renal damage in these patients. And I hope that very soon we may have these markers for detecting early renal damage, and maybe the ACE inhibitors will come into practice in the years to come. Thank you very much for a patient hearing.
Thank you, Dr. Mandalia. Are there any questions in the chat box directed to Dr. Mandalia? Okay, if there are none, then Dr. Ankur, I'd like to ask you that this was a study. Have you put the findings of the study into any kind of a clinical practice in your unit? Are you doing it on a regular basis?
Ma'am, currently we don't have the cytokines in the regular clinical practice, but as Dr. Sachit said, that soon we might have ELISA kits whose cost might be as low as 350 to 500 rupees. So if once, as and when that becomes available, we definitely should start doing it. But currently we are not doing any of these markers.
All right. Thanks for throwing. Any other question from the audience over here in the hall? If there are no further questions, then can I call upon Dr. Mehak Saigal to deliver her talk on differential expression of molecular markers in urine with respect to general genetic properties in congenital uropathies. Dr. Mehak.
A very good afternoon to the chairpersons and delegates. From AIIMS New Delhi, I will be presenting our experience with a set of biomarkers and their differential expression in urine with respect to genetic propensity to congenital uropathies. Congenital uropathies are known to be a common cause of end-stage renal disease in children, and renin-angiotensin system is postulated to be involved in the mechanism of renal damage. Congenital anomalies of kidney and urinary tract have a complex genetic basis which has a strong influence on the outcomes of these conditions. The prevalence of these genetic mutations in children can alter their response to treatment and lead to varied phenotypic outcomes. This work is in continuity with our previous work on genetic polymorphisms in patients with congenital uropathies on nephrogenic genes and those involved in the renin-angiotensin pathway, where we found that polymorphisms in the nephrogenic genes were not found to be associated with an increased incidence of renal scarring in the Kakut group. However, presence of depolymorphism in the ACE gene was seen to be associated with a significantly increased incidence of renal parenchymal disease as assessed by renal scarring in these children with Kakut. In this study, we aim to identify those subsets of patients with differentially high expression of urinary cytokines and enzymes and to analyze their genetic propensity to end-stage renal disease vis-a-vis those with stable disease. The aim of our study was to evaluate the role of the following biomarkers in the diagnosis and management as early markers of progressive renal kidney damage in children with congenital uropathies, namely PUJ obstruction, posterior urethral valve, and VUR, vis-a-vis the conventional markers of renal injury, which were we looked at urinary enzymes, namely voided urinary N-acetyl beta-D-glucosaminosidase, alkaline phosphatase, and gamma-glutamyl transferase. We also looked at urinary cytokines, transforming growth factor beta-1, tumor necrosis factor alpha, and interleukin-6 and microalbumin. We also aim to study the effect of the following mutations and genetic polymorphisms in the pathogenesis of congenital malformations and to compare the degree of renal injury in both groups, namely angiotensin converting enzyme gene with IND allele, angiotensin II receptor, PAX2, and BMP4. The study was conducted in the Department of Pediatric Surgery from November 2019 to July 2021 in the Pediatric Urology Clinic at the All India Institute of Medical Sciences, New Delhi. Patients with a diagnosis of congenital uropathies of posterior urethral valve, pelviureteric junction obstruction, and primary vesiculoureteric reflux were included in the study, and this was a cross-sectional study. We had a total of 70 patients with male predominance, equally distributed among the three diagnoses. As we do not perform GFR and DMSA scan in patients with PUJ obstruction, only 45 children were included for this sub-analysis. On comparing the biomarker concentration between cases and control, we found that the biomarker concentration was significantly higher in cases than in controls. Subsequently, we compared the various biomarker levels among the three diagnoses and found that the levels were higher in children with obstructive pathologies of PUJ obstruction and PUV and lower in cases of VUR. We found moderate to good correlation between the biomarkers. On comparing the biomarker concentration in children with and without renal scars, we found that the median concentration was significantly elevated for urinary N-acetyl beta-D-glucosaminosidase, GGT, and TGF-beta in children with renal scars. The NAG and TGF-beta also had the highest area under curve in their respective receiver-operator characteristic curve. On comparing the urinary biomarker concentration in children with and without a GFR less than 90, we found that the median urinary concentrations of TGF-beta and GGT were significantly elevated in children with a low GFR. GGT and TGF-beta also had the highest area under curve in their respective receiver-operator characteristic curve. In a multivariate linear regression analysis, NAG and TGF-beta were the best predictors in children for a low GFR. We then compared children with and without an antenatal diagnosis and found that urinary ALP was elevated in children with an antenatal diagnosis. On comparing the urinary biomarker concentration in children with genetic polymorphisms, we found that out of the 78.5% children with BMP4 polymorphism, with the presence of an A allele, biomarker concentrations were not significantly increased in either group except for ALP. Similarly, none of the biomarkers were elevated in the 65% children with PAX2 polymorphism with a presence of G allele. On analyzing both the nephrogenic genes combined, we still did not find any significant difference between the two groups. Similarly, we did not find any difference in the urinary biomarker concentration in children with and without ACE and AT2R polymorphism. However, when we compared the urinary biomarker levels in children with renal scarring with and without ACE polymorphism, we found that the levels of NAG, GGT, and TGF-beta were significantly increased. We subsequently also evaluated children with nephrogenic gene mutations and evaluated them for genetic polymorphism in the RAS pathway genes, which were ACE and AT2R. And we found NAG to be significantly elevated in children with ACE D allele. On comparing the biomarker levels in children with nephrogenic gene mutations with renal damage, with and without ACE polymorphism, we found that the levels of NAG, GGT, and TGF-beta were significantly increased in children with a D allele. This thus corroborated with the second hit hypothesis of renal damage in children with Charcot. Congenital anomalies of kidney and urinary tract are the most commonly identified malformation, representing 20 to 30% of the antenatally diagnosed fetal anomalies. And that is where the multiple biomarkers have been studied, as they are overexpressed in the pathway of renal damage and may help us potentially identify early the renal damage that is occurring. There have been various other studies by A.G. and Wolf and others that have established the role of nephrogenic genes in Charcot. There have been studies on genes involved in the renin-angiotensin pathway like ACE gene, which have established its role in causing renal damage even from our department. This is an oversimplified figure representing that although the nephrogenic genes are implicated in causing congenital anomalies, but the influence of the RAS system polymorphism may confer additional damage in these patients. The biomarker concentrations are significantly elevated in this subset of patients as seen in our study, and thus biomarkers along with genetic polymorphism identification can potentially have a practical utility to identify high-risk group of patients who need close monitoring and may need subsequent ACE inhibitor therapy to prevent further renal damage. Thank you.
Professor Bartoli, if there's something you would like to ask this presenter.
Yeah, it's very interesting. Well done study. This about the role of gene predisposition for development of renal damage, and the colleague has clearly demonstrated that this is true. The question is that the percentage of patients that have this gene polymorphism are still quite limited. Or you have found a high percentage of patients with this polymorphism on the population of children with Charcot?
Sir, nephrogenic gene polymorphism was found in 65% patients with PAX2 and in 75% patients with BMP4. And ACE inhibitor, the ACE gene polymorphism was again found in 76% of the patients, and AT2R gene polymorphism in 80% of the patients.
So you suggest this should be gene polymorphism become routine evaluation on these uropathy patients, so I suppose.
Yes, sir.
Because it's not always done worldwide. It's quite uncommon. Then urology center study gene polymorphism, but on the basis of your study should be routine study of this polymorphism.
Yes, sir. Because this can potentially help us identify those children that require close monitoring, because as we saw that the urinary biomarker concentration was elevated, especially in those children with renal scarring with and without the polymorphism. So those that had the polymorphism had a much higher concentration, which meant that the damage was more in these patients.
Thank you very much. It's very interesting observation. Thank you.
Thank you, sir.
Thank you, Professor Bartoli. Now I invite Dr. Alisha to present her talk on urinary NGAL levels in children with extrophy bladder, premonition of renal damage. Dr. Alisha.
Thank you, ma'am. Good afternoon, everyone, once again. Tagging along the discussion on the role of urinary or biomarkers in children with congenital anomalies of the kidney and the urinary system, I will be discussing on one specific biomarker, the neutrophil gelatin associated lipocalin level in children with extrophy bladder and how this can be used for monitoring and premoniting renal damage in these children. As we already know that congenital anomalies of the kidney and urinary tract are quite common, to the extent of 3 to 6 children per 1,000 live births, accounting for 30% of all congenital malformations. More important than that is the fact that this is the most common cause of chronic kidney disease in the long run. Reasons being, firstly, inherent dysplasia, and secondly, progressive deterioration, either due to delayed diagnosis or due to surgical insult. Extrophy bladder is one congenital anomaly that has the advantage of not having any inherent dysplasia or not having a delayed diagnosis. However, progressive deterioration can occur and does occur due to severe surgical insult. So whether this is a modern staged repair or a single stage repair, it is very important, hence, in these children to continue follow-up, either with the use of biochemical markers such as serum creatinine or use of imaging and nuclear medicine screening. The disadvantages, however, is the fact that children are born with a very good renal reserve due to compensatory hyperfiltration, and it takes up to 50% of the nephrons to get damaged before the creatinine values start to rise. And by this time, half the battle is already lost. And with the nuclear scans, the cost, resources, and the risk of radiation involved, and the use of potential sedation in children limit their frequent use. And hence we need markers or assessment or tests that can, first of all, detect renal damage at its very inception, and they're easy to perform. And one such test is the use of urinary enzyme biomarkers. And we propose that if the inception of renal damage can be picked up by these markers, at the time when it is still salvageable, these can prove to be pre-monitors of renal damage. Just to briefly explain the role of neutrophil gelatinase associated lipocalin. So NGAL specializes in binding and transporting small hydrophobic molecules and is released by lysosomes, brush border, and cytoplasm of proximal tubular cells. A study by Mori and Nakao in 2007 related this to sustained production by inflamed but viable tubular cells, leading to NGAL being a real-time indicator of active kidney damage. Whereas they proposed that increase in serum creatinine and decrease in GFR were merely the passive results of loss of functional nephrons. NGAL has been measured in plasma as well as urine. The plasma levels being more depictive of systemic inflammatory responses secondary to pyelonephritis, whereas urinary levels more directly related to renal epithelial insult, such as in children with hydronephrosis, urolithiasis, etc. Several studies have been performed and have been discussed over the course of the day today about the role of NGAL as one of the biomarkers in CACUT. And one of these studies by Dr. Anand et al. Showed significantly elevated concentrations of the NGAL levels in children with CACUT as compared to controls, with a positive correlation of increasing values with deranged upper tract function. Similarly, the role has been proved multiple times, and in a systematic review published back in 2014 about the NGAL predicting need for surgical intervention in children with antenatal hydronephrosis and children with surgically treated pelvic-ureteric junction obstruction having significantly higher levels as compared to healthy controls. Similarly, the role as a diagnostic marker and a predictor of scarring has been proposed in the psychoureteric reflux and in children with lower urinary tract obstruction. The study by Kovacic et al. Proposed that raised NGAL levels were present despite normal serum creatinine levels, signifying early initiation of renal tubular damage in children with urolithiasis. And other studies have proposed that longitudinal follow-up is more predictive than cross-sectional values in predicting scarring and other components of renal damage. Previously, medical renal conditions have also studied the role of NGAL extensively in diseases such as stage 3 or 4 chronic kidney disease, glomerulonephritis, etc. So the aim of the present study was to study the role of urinary NGAL levels in children with bladder extrophy post single stage total reconstruction as markers of early renal function derangement. For this, we made 3 groups. The first group being children with newly diagnosed bladder extrophy, that included 11 children. The second group being 40 children who were more than 5 years follow-up post single stage total reconstruction for bladder extrophy, and 41 age-matched controls with healthy kidneys and bladder. 3 mL of urine sample were collected either with clean catch or with catheterization of the ureters intra-op in children with bladder extrophy. And the presence of infection was excluded by a urine dipstick, and these were stored at -20 degrees Celsius unless they were enough to be ready for a double antibody sandwich ELISA detection of NGAL. So coming to the results, we realized that there was a significantly higher level of urinary NGAL in children who were follow-up cases of bladder extrophy as compared to the newly diagnosed cases, as well as compared to the age-matched controls. Comparing urinary NGAL levels vis-a-vis scarring on DMSA scans showed significantly higher levels in children with scarring as compared to children without scars. And comparing the urinary NGAL levels vis-a-vis GFR showed a significantly higher level in children with a GFR less than 80 mils per minute per square meter body surface area as compared to children with more than 80 GFR. Specifically focusing on group B, which was the follow-up children with bladder extrophy. Here in these 40 patients, when we compared the NGAL levels in children with a high and a lower GFR, these were comparable and high. So we concluded that it did not make a difference whether the GFR was high or low, and children who were more than 5 years follow-up for extrophy bladder had high NGAL levels already. So to summarize the results, we noted higher levels in follow-up of extrophy bladder as compared to the newly diagnosed cases in the controls, higher NGAL levels in children with scars as compared to ones without scars, higher levels in children with a lower GFR as compared to a high GFR. And just comparing within the follow-up cases, it did not make a difference whether the GFR was high or low, and the NGAL levels were comparable and high. Sidelining and doing another deviation of the study in the freshly diagnosed cases of extrophy bladder and comparing them at 6-monthly intervals after the primary repair, we noted that they had a normal NGAL level at baseline and at the first follow-up. However, at the 12-month follow-up, there was a steep rise in the NGAL levels, and that later plateaued. So we noted that 12 months was the time when the GFR and the DMSA scans were still normal mostly. However, the NGAL levels had already increased. So we concluded that the urinary NGAL may not be simply a surrogate index of GFR, but a marker of its own, predicting chronic kidney disease progression or renal damage beyond the information provided by GFR. And it should be not long before this could be labeled as a renal troponin. Thank you. I thank Professor Bajpai for allowing me to be a part of this study whilst I was working and training back at AIIMS. Thank you.
Are there any questions in the chat box? In that case, we will go on to the final topic of this session, that is Professor Vera Koch. So I invite Professor Vera Koch to speak on should biomarkers to be added to the surgery indication algorithm. And I would then request Professor Bartoli to direct his questions towards Professor Vera. Professor Vera?
We have a pre-recorded presentation of Professor Vera, so we'll play that and she'll then be available for the question answers.
Questions? Starting to all.
Importance of novel renal biomarkers in the diagnosis of upper urinary tract infection and surgical significance in pediatric patients. This is a common and challenging neurological condition caused by a variety of diseases in pediatric patients. The most frequent one is UVGO, whose prevalence is 1 in 200.
Sorry, I cannot listen.
Some observed these patients, but its extent does not necessarily reflect the severity of the obstruction process. But we end up using to diagnose the need for surgery and zero cracks in the variations, which, although time-consuming and very distressing to the child and to the family, are not sensitive or specific enough to identify those defects that require treatment in all cases. In this slide, we can see the mechanisms of UVGO that cause significant differences. So the increased pressure in the urinary system leads to tubular subtraction, urinary shield stress, which cause
I cannot listen the lecture.
and also indirect mechanism that involve stimulation of rank angiotensin aldosterone system, which induces both an inflammatory process and a decrease in renal blood flow and steam, which have as an end result tubular cell death, an increase in the presence of fibroblasts in the lymph tissue, increase in extracellular matrix and fibrosis. In this slide, we can see the 3 groups of novel renal biomarkers that are mostly studied. The first group are biomarkers of fluid injury represented by T1 and NCAL, which are produced by the proximal tubule and are increased early after kidney injury. The second group of biomarkers of kidney function, the most important ones are cystatin C and alpha 1 microglobulin. These are proteins that build up in the urine due to tubular disruption. And the third group is constituted by biomarkers of inflammation, including cystatin 18 and ECP1, which are produced as part of the inflammatory response regulation. Many urinary biomarkers have been studied in children and adults with UUTO. The most extensively studied are MCP1 and NGAL, and they are also the most likely to be optimal. It's important to understand that no single biomarker is adequately sensitive or specific. A panel assessment is needed to afford mutual biomarker compensation and to improve predictive performance. It's also important to have in mind that obstruction per se and reduced GFR in the affected kidney decrease the amount of any biomarker reaching the bladder, limiting the performance of bladder urinary markers. So a combination of serum and bladder urinary biomarkers improves performance. Urine NGAL levels are significantly higher in bladder urine or renal pelvic urine of children with UUTO versus controls, and correlate inversely with worsening obstruction, and they also decrease after surgery. MCP urinary levels, MCP1 urinary levels are significantly increased in UPGO groups compared to controls. They fall significantly after surgery and can be used to monitor the resolution of kidney damage after surgery for UUTO. It's important to know that serum MCP levels have not been evaluated in UUTO patients. Urine KIM1 levels also correlate inversely with worsening obstruction. And in children with UUTO, they have been studied and they are known to decrease after surgery. There are novel biomarkers represented by venin-1 and alpha-glutathione as transferase. They are also expressed in proximal tubule, as are most of the renal biomarkers that we currently study. They have outperformed traditional biomarkers in terms of evaluating UUTO, but they need further work to explore whether this is the case for all UUTO settings. Urine NAG levels detect child UUTO, but do not reflect its severity. And the utility of LFABP for predicting UUTO remains controversial. Here I present to you the papers that mention this information, and I invite you to read them, because they will really make up your mind of the importance of these renal biomarkers in the understanding of the obstruction process and in the surgical indication of these cases. There are novel biomarkers. They are represented by beta defensins, BD1, LL37, and HIP-PAP. They are cationic antimicrobial peptides. And HIP-PAP has also antioxidant, anti-inflammatory, mitogenic, and anti-apoptotic effects. They are important in the maintenance, integrity, and homeostasis of several organs. And it's been shown that urinary levels of BD1, as well as NDOL, LL37, and HIP-PAP were significantly higher in UPGO patients than in controls, and HIP-PAP and BD1 expression significantly decreased upon paired analysis after successful surgical correction of UPGO. It's important to know that these biomarkers were studied in a few studies, so their importance in the literature is not as expressive as MCP1 and NDOL, which have been extensively studied in this situation. So to answer our question, should biomarkers be added to the need of surgery algorithm? The answer is probably affirmative, but the existing studies follow different methodologies for patient and biomarker selection, so a consensus is needed. We feel, this is our personal impression, that a multicentric and multinational study is mandatory to determine not only which biomarkers should be used for UUTO diagnosis and severity degree evaluation, and consequently surgical indication, but also for patient follow-up and long-term kidney function prognosis. I thank you very much, and I leave my email for further communication. Thank you.
Thank you very much, Professor.
Is there any questions on the subject in the chat
box? If there are none, I would request Professor Bartoli to ask Dr. Cox
Thank
anything
you
or any
very
comments
much,
on the lecture that he would care to
Professor
give. Professor
Vera,
Bartoli.
for this nice lecture, which basically resume what is in literature. But today, I think we have, listened to very
If there are
interesting.
no comments or questions over,
Yeah.
there
Today
is
we have
one.
listened
Okay.
to
Yeah.
very interesting study
He's
about.
not available. In that case, oh, he's trying to say something. How do we get him audible?
Sorry, I don't know. I don't.
Yeah. Any comments or any questions on Professor
Yeah.
Cox, Dr. Professor Bartoli?
Yes. No, I was wondering after this session, it's quite clear that biomarkers alone might be quite suitable to address treatment in the long term, especially those evidenced like in the angiotensin system, which have been clearly shown to be to have a role in management of this patient. As long as also polymorphism, gene polymorphism, is a quite interesting aspect of you. Have you also have considered gene polymorphism review on your lecture? And eventually, if you have also had the option to see the role of corticosteroid in treatment of this Charcot disease.
Well, not really. I think my main point here, in our study, first we characterized what's normal in terms of biomarkers. So I didn't use my time to tell you what our studies are because they are published. Okay, so we characterized what's normal. So there is a normal increase in biomarkers in infants, as you know, when you are born, especially if you are premature, your kidney is still developing. So we have to know what's normal in kids as they grow. So we characterize that with many other authors. And then we studied what would biomarkers help us in the diagnosis of antenatal hydronephrosis and the need for surgery. This is done. I think this is done in the literature. But I understand the role of genetic polymorphisms, and I thank the presenters, to bring this back. But what I think is important, we are doctors. Our mission is to help kids. So what we know is that surgery is delayed presently, very delayed. We need a structured diagnosis to understand if this child has to go for surgery or not. Most of the antenatal hydronephrosis cases, as we know in 2021, do not go for surgery. Is this right? Do we have long-term follow-up of these cases? We do not. Most of the services, they just discharge the patient because they say, oh, everything is okay. We need a structured diagnosis. We need biomarkers in our clinical practice so that we can separate which kids have to go for surgery and which kids go for observation. And if they go for observation in our clinics, should we still use biomarkers or not? We need a consensus. We need a multinational study. And why multinational? Because these biomarkers are expensive. I come from a developing country. I live in Brazil. All my studies come from Brazil. I had to ask for special research money to get biomarkers in my clinic. I cannot, as the guy from India, as our colleague from India, I think it's the same. So we need a multinational consensus as to the importance of biomarkers. So they can't come to clinic. We have to have them in clinic, following our patients so that we can understand which kids go for surgery. And if surgery is immediate, it has to be immediate. If it has to be in 2 or 3 months, I mean, we have to know that. And as we are in the literature, we do not know that. Because one colleague studies 20 patients, the other 30 patients, the other 15 patients. One uses a cocktail, another uses a different cocktail of biomarkers. We are nowhere. We know they are important, but how? How can we bring that to patients? We do not know. And it's already 2021, almost 2022. So this is my
personal opinion, Professor Koch, that biomarkers alone will be difficult that will address surgery or not, because
no, I understand. You're right.
The clinician and the surgeon, you know, is a complex decision making, not only on lab, but on clinical and experience judgment. But of course, biomarkers will help us to timing eventually treatment or to get better results from treatment, like ACE inhibitors or corticosteroid, to decrease the effect of inflammation even after surgery, because we know that damage still is ongoing after surgery, but at lower rate.
Oh, I understand. We use renal scans, we use ultrasounds, but in our experience, I mean, in our study, with biomarkers, we could indicate surgery at least 3 months beforehand. And 3 months is a lot, because we have to understand that the kidney is under pressure. There is a lot of pressure in the urinary system, and this pressure leads to inflammation, and inflammation leads to fibrosis. So if this child can experience inflammation for a shorter period of time, maybe the long-term renal function will be better. So we have to move forward. Of course, we need ultrasounds. Of course, we need DMCA and all the radionuclide studies we use. Of course, we need to avoid infection. If infection is another problem, if this child gets an UTI, an urinary tract infection, more damage. But I think we have to move forward in terms of having a structured way of looking at this child. And I know that not the urinary biomarkers, maybe plasma biomarkers as well, for instance, maybe they have also a place. We have to use them, and we have to make this diagnosis as soon as possible. We have to operate these children as soon as possible and follow them.
But we are short of time. It's like the pressures of urine. So I thank you very much for your participation in your talk, and I thank Professor Bartoli. Over to Professor Bajpai.
Yeah, just a brief comment on Professor Koch. Yes, we fully agree. Professor Bartoli, you would also agree that if we have to have a reversal of disease process before the damage really is inflicted, that's the way to go. And Professor Bartoli, you are right. We have to do imaging, and as Dr. Veera also said, we have to do imaging to make a diagnosis, and then with the early markers, we can do the disease reversal. Otherwise, what people used to call programming, it was not programming. Actually, it was periglomerular fibrosis, which becomes fixed, and then the damage continues. And that's when we find that the function is not recovered. I think biomarkers may take us in that direction. So thank you very much, Dr. Veera Koch, Professor Bartoli. It was a wonderful experience sharing with you. Anything, Professor Bartoli, you want to give a last comment?
Yeah, that I would love to come back to Delhi to visit this beautiful India and nice colleagues like you, really.
Thank you.
Thank you very much for inviting me.
Thank you very much. Thank you.
Thank you again for listening. This is really expert lecture and contributes. Okay.
Thank you and namaste from India. And now I invite Dr. Ramesh Babu would like to deliver certain comments. Dr. Ramesh Babu.
Yeah, can I just share my screen and show a little bit, just one or two slides?
One or two slides is okay. Then we have duration.
Yeah, I know. I'll just show you because this is so important to what we are talking today. I thank Dr. Bajpai and his team for being the pioneers in this field. And are you able to see my screen?
Yes.
Yeah, so we just did the systematic review and meta-analysis on a role of biomarkers in relation to uretropelvic junction obstruction. This is just what Dr. Koch was saying. There are so many biomarkers, and we wanted to pin down on the commonly used biomarkers. And so we did this meta-analysis, and our findings were kind of interesting. I won't go into the methodology. I will just want to say, so there were 10 publications on NGAL, 6 publications on MCP1, 6 publications on KIM1, 5 publications on CA19-9, 3 on EGF1, 3 on IP10. Now, when you look at the combined data of all these things, so when you look at the overall sensitivity, the sensitivity was the highest for CA19-9, and the specificity was highest for NGAL. And when you look at the accuracy, which is a combination of sensitivity and specificity, it was highest for CA19-9, followed by NGAL, followed by KIM. Now, like how Dr. Veera Koch was said, there were so many articles, like one Caracas was mentioning these two are the top 2 markers, and then there are other papers favoring each biomarker. For us, these are the top performers based on the accuracy. Only problem is the cutoff range, what each author quoted, is quite variable. It ranges from 0.8 to 20, that much of 0.4 to 900. So that much of variation is there in the cutoff. And as Dr. Koch has rightly pointed out, several authors have come to conclusion that a marker panel, a panel of 3 or 4 markers is the best to improve the accuracy. And we, based on our meta-analysis, suggest that NGAL, KIM, and CA19 are the biomarker panel which you can use for uretropelvic junction obstruction. So that's what we have come out from this meta-analysis. And probably the next research we are going to do is focus on these 3 biomarkers, NGAL, KIM, and CA19-9. Now, one of the problems which we could face in these studies is like the cutoff values. We have to establish cutoff values, and that will be a challenge. And as Dr. Koch was saying, it needs a multi-institutional study to find out what is the ideal biomarker and is there an age or sex related cutoff for each biomarker. So all these things we have to look at it. But our meta-analysis favors a panel of biomarkers combining NGAL, KIM, and CA19 for uretropelvic junction obstruction in children. So that's what I want to say. Thank you.
Thank you. Thank you very much.
Thank you, Dr. Ramesh. With that, we come to the close of this session, and we will proceed to the orations, if I understand correctly.
Before moving on to the oration, we will now have a brief presentation on Asian Society of Pediatric Urology and Indian Society of Pediatric Urology by Dr. Sachitanand.
Good evening to all. I'll be giving a brief talk about the Asian and the Indian Societies for Pediatric Urology. The first congregation happened in 1998, and eminent scientists, including Professor Gerhardt, were invited and they joined us for the meeting. These are some of the classical pictures from our archives where Professor Bajpai, Professor Jayant Radhakrishnan, Professor Upadhyay, and Professor Dave are there. This is the lecture which was given by Professor Bajpai. Over the years, this is the 24th year of the societies, and we have had 20 meetings in India and abroad, and 13 joint meetings by ISPU and ASPU have been conducted, and all major topics of pediatric urology have been covered. This is the website for our societies, which includes the current program and the upcoming events, which is happening in February 2022. And the past events are also displayed here. It also includes the names of the awardees and our journal. This is the first announcement from the society, which is regarding the upcoming meeting, which will be our 25th year of ISPU and ASPU. And this will be on, the symposium will be on bladder extrophy epispadias complex, and many eminent pediatric urologists are joining us from Children's Hospital, Philadelphia, from Seattle, from Toronto, etc. This is the second announcement that on conference day 1, we'll be starting with our annual lecture series, and this will be held once or twice per year. Since it is our 25th year, it is fondly known as Silver Lecture Series. And the lecturers for these sessions will be 2 pediatric urologists in early and mid-career. And lecture topics will be decided, and the presentation will be in front of an esteemed panel, and it will be displayed like this on a YouTube as well as on our website. We will be deciding the names, and they will be updated to you soon. The third announcement is regarding the Best PG Thesis Award, and it will be awarded to pediatric surgery resident with dissertation in the field of pediatric urology. The terms and conditions will be displayed soon on the website, and the applications are starting on 1st January, and they will be till February 15th. Last but not the least, we are having the rejuvenescence of our journal, and the next upcoming issue will be in January 2022. We now move on to the orations. And Dr. Kirtika will take over from here. Thank you.
Thank you, sir. We shall now proceed to the much awaited and the prestigious ASPU oration. This year's ASPU oration will be given by Professor Sandeep Agarwala, who is a professor of pediatric surgery, AIIMS, New Delhi. Professor Agarwala is a graduate from AIIMS in 1986 and has completed his MCH from AIIMS in 1991. He has been a faculty at AIIMS since 1994. His research interests include pediatric surgical oncology, thoracic surgery, and neonatal surgery. Professor Agarwala is responsible for the Pediatric Surgical Oncology Clinic at Cancer Center of AIIMS. He is the chairman of the work group for national guidelines of standard treatment workflow in pediatric surgery by the Department of Health in ICMR. He is an executive board member of the AAPS and was a member of the executive board of the International Society of Pediatric Surgical Oncology, the chair of the Surgical Oncology subsection of the Indian Association of Pediatric Surgeons, and is currently the co-chair of the Resource Challenge Nations Committee of the SIOPL. He is the section editor for the Indian Journal of Pediatrics and has been the editorial secretary of the Journal of Indian Association of Pediatric Surgeons. He is a faculty for the masterclass in pediatric surgical oncology conducted by the European Board of Examinations and IPSO. He is the resource person for the nursing training program by the WHO. He has been the organizing secretary for multiple workshops, CME, and conferences, and has presented and chaired at multiple international and national conferences. His work has also been awarded at multiple international and national conferences. He has over 300 scientific publications and more than 90 chapters in books. He is a co-editor of the book Basic Techniques in Pediatric Surgery, an Operative Manual. Sir is a humble, dedicated person and is a favorite among his residents for his keen interest in teaching. Sir, I request you to please come up on stage to receive the ASP oration plaque. I request Professor Bajpai and Professor Mitra to give the plaque to Sandeep.
yet? Okay. Next is so good evening all. At the outset, I thank the Asian Association of Pediatric Urology and specifically Dr. Bajpai to have awarded me this oration for this year. The topic that has been awarded to me is to talk on rhabdomyosarcoma of the bladder and prostate. So a brief introduction about rhabdomyosarcoma is the primary malignancy basically of cells which are destined to become skeletal muscles. So they may be found in areas where we don't normally find skeletal muscles like the urinary bladder, but they are the original mesenchymal cells. It is the third most common extracranial malignancy and the most common sarcoma in children. Genitourinary site is the second most common site of the rhabdomyosarcoma, and of this, the commonest site is the bladder and prostate. However, because these tumors are not so common in children, the bladder and prostate RMS usually constitute only about 2 to 4% of all childhood malignancies, which basically highlights that even in a busy oncology center, you may see 2 or 3 cases in a year. So to accumulate data, it needs a large number of years or a large number of centers to come together to have a good data. So 25% of the rhabdomyosarcomas are in the genitourinary sites, and these are classified as unfavorable sites or favorable sites. The bladder prostate is one of the unfavorable sites, and this we'll see how it comes in handy when we are risk categorizing these patients. And bladder site is more common than the prostate site. Unfortunately, nearly 1/5 of these patients are metastatic at presentation. Most common site of metastasis is the lungs, but other sites like bone marrow and bone and lymph nodes are also there. Now, there are some differences in bladder and prostate, which I will highlight later. But as we see, it is seen in small children. Median age is around 3.5 years, and it could be in the dome or in the bladder base, very common site, the trigone and the prostate. Most of them are embryonal rhabdomyosarcoma of the botroid variety, and nodal involvement is not very common. And as I said, this is an unfavorable site amongst the rhabdomyosarcoma. Now, prostatic tumors are usually large pelvic masses present with urethral strangulation and constipation, and they are solid rather than botroid, and often are metastatic to lungs and bone marrow, as compared to bladder tumors, which are usually smaller pelvic masses, may present with hematuria, passage of polyps, retention or overflow incontinence, and sometimes with UTI. They are usually of the botroid variety and usually localized at presentation. Histology has seen a lot of change over the years and how we look at the bladder prostate rhabdomyosarcoma. It is one of the small blue round cell tumor, as we call the neuroblastoma, lymphomas, Ewing's, and the international classification of RMS, which is used normally, is now being slowly replaced. The embryonal RMS, which forms around 70%, is divided into botroid variety, the spindle cell variety, and not otherwise specified variety. And the alveolar RMS, which is about 30%, is the other type of RMS. Initially, there used to be a percentage that unless there is 30% or 40% of the tumor is alveolar, we can't call it alveolar. But now, if there is any alveolar in the tumor, it is called alveolar. And now more and more the genetic alterations are being studied. 80% of the embryonal RMS have loss of heterozygosity at 11p15. And this results in the overexpression of IGF-2, which is important for tumor growth. And this is now used as a target for the newer molecular therapies, which are now coming into vogue more recently. The other tumors which have this deletion in the short arm of chromosome 11 are the commonly that we see are Wilms tumor, neuroblastoma, and hepatoblastoma. Now, the alveolar rhabdomyosarcomas, most of them have a translocation between the PAX3 on chromosome 2 and FOXO1 gene on chromosome 13, and or they can have PAX7 on chromosome 1 and FOXO1 on chromosome 13. So these are the two most common translocations which are seen and now being used for, actually instead of the standard histological classification, these are being used. So 10 to 20% of alveolar rhabdomyosarcomas are translocation negative, and these closely resemble the embryonal rhabdomyosarcoma and also have the same prognosis. So the newer classification histologically, which is used now with the COG soft tissue sarcoma group, are fusion positive and fusion negative. So those which are fusion negative are treated like what embryonal rhabdomyosarcoma used to be treated, and those which are fusion positive are actually the actual rhabdomyosarcomas. And we have all heard about the intergroup rhabdomyosarcoma study group, which was established in 1972. And over the years, we see they have conducted a large number of multinational, multi-centric studies. And the last one, the IRSG5, which concluded in 2000, has its results out, which are now we quote everywhere. From 2000, the IRSG has been disbanded. And what is now is the Children's Oncology Group, soft tissue sarcoma study groups. So 2000 to 2006, there was one, and since 2006, there's other. So they actually come out with protocols after having looked at all the factors. So these study groups use the staging system, and basically for rhabdomyosarcoma, still we are using two staging systems in combination. The clinical grouping is also very important, which is a surgico-pathological staging system. And if a tumor is not resected, only biopsied, it becomes CG3. So it is something which is important for resection, but now as we know, a lot of tumors don't undergo upfront resection. So the classification needed to be changed. The TNM or pre-treatment staging system is also by IRSG. And this is the clinical grouping. As I said, group 1 and 2 are those which have undergone resection. Group 3 is those who have not undergone resection, and 4 are metastatic. When we look at the TNM staging, they use the site, and I've already mentioned favorable and unfavorable sites, tumor invasion, the size of the tumor, regional lymph nodes, and metastasis, like all other TNM staging systems. And these are the TNM system. It looks complex, but it is very simple. All favorable sites, if they are non-metastatic, are stage 1. If they are metastatic, they become stage 4. And the unfavorable sites are divided in between. Any metastatic tumor is stage 4. So unfavorable sites of tumor, which are lymph node negative and less than 5 centimeters, are stage 2. But if they're either or more than 5 centimeters or lymph node positive, they become stage 3. So it's a very simple classification. But routinely in the clinics, we use this table and mark out, as I will show in examples, how we can stage these patients. There are various prognostic factors which have been identified for rhabdomyosarcoma. And based on these prognostic factors, the risk categorization is done. And based on the risk categorization, the further treatment is done. The age is an independent prognostic factor. We used to think that younger children have more embryonal sarcoma, so they are better. But it is an independent prognostic factor. And children less than 10 years fare better. Histology, as I mentioned already, the alveolar rhabdomyosarcoma fares worse. In the clinical group, if you look again, the stage matters in the outcome, and this is significant. And even in the TNM staging, the stage matters, and this is significant also. So the risk categorization is made using both the clinical groups and TNM groups. We have a low risk, intermediate risk, and high risk. Low risk is further divided into subset A and subset B. And this is based on the outcome. So a low risk subset A has an excellent outcome of more than 85% survival, while subset B has about 70 to 85% survival, while intermediate group has survival of 50 to 70%, and high risk group have survival of less than 35%. The treatment is according to these, and the most common drugs which are used, we all know, is vincristine, actinomycin D, and cyclophosphamide. So for low risk group, still vincristine and actinomycin is used, while for the low B, intermediate and high, the VAC is used with or without radiotherapy, as the condition may be. So the risk adapted therapy, which was used with IRS5, is mentioned here, but I don't think we'll go into the details. What is more important, that a lot of patients receive radiotherapy, except for clinical group 1 and low risk A, everybody else receives radiotherapy. And this is important in the long-term outcomes of this patient. And for the high risk groups, the various newer drugs are being tried. Unfortunately, from IRS 1 through IRS 5, so the last 30 decades, we have not been able to improve the survival rates. So the IRS 1 came on the backbone of surgery, where pelvic exentration was done, and the survival rates were in the range of 65 to 70%. It is still the same with all these drugs. So that brings us to the question of the long-term complications in these patients. So the newer rationale for the COG, sorry for this mistake, so COG STS study is to maintain excellent outcomes while minimizing acute and long-term toxicities. So these are the various low-risk protocols which are in vogue right now. And what they have done is they have tried to decrease the duration and the dose of cyclophosphamide. Now, cyclophosphamide is something which is very toxic. We don't realize. Acute toxicity, we all know, the blood counts go down, but they make all the patients azoospermic. So all the patients of rhabdomyosarcoma who have got 2.2 grams per meter square of cyclophosphamide will be azoospermic, which is a very big long-term complication. Radiotherapy also has a lot of complications, acute and in the long term in these patients, and it adds to the infertility in these patients. So the newer novel agents which are now being tried are irinotecan and these monoclonal antibodies against IGF-1 receptors, and temozolomide, which is again an alkylating agent, which acts in synergy with irinotecan. So various window protocols or additional protocols are being tried, and we hope to improve the outcome with these things, but we are still not so sure what is going to happen with these. So for bladder prostate rhabdomyosarcoma, local control is also very important. And the timing of local control has always been very controversial, whether it should be done at 9 weeks or 12 weeks. So chemotherapy is a systemic therapy. What are we going to do the primary tumor? Are we going to resect the tumor or give radiotherapy or do both? Now, most of the surgeons would resect the tumor if it is easily resectable without too much of problems. Or we give radiotherapy. Sometimes even after resection, radiotherapy is required. Another thing which has come across very clearly is that when we do a CT scan, we find a residual mass on imaging. It is not always viable tumor, which was shown by IRS 3 that 36% of the patients which were non-responsive on CT scan, I mean the mass still remained as it was, were histologically in CR when they were biopsied. When the resection was done, they were all in CR and either fibrosis or rhabdomyoblast. So we should not give up on the patients just because the tumor is not responding. We have to confirm that it is actually tumor which is still there. So the goal of resection in bladder prostate rhabdomyosarcoma is always to achieve a clearance with bladder salvage. But this can be achieved in only 60% of the patients, even now after neoadjuvant chemotherapy and radiotherapy. And exenterative surgery is still required in 30% of the patients to save these patients. This is the problem that we face, especially in our scenario in India, where parents usually refuse exenterative surgery because they don't want to have a catheterizable stoma for life for the child who is now 3 years old only. So bladder-based tumors often require major resections with and without augmentation and usually with reimplantations. But what is more important to realize that even when we say 60% of the patients, the bladder resection can be achieved with conservation of the bladder conserved is normal only in 50% of these patients. So anatomically conserved bladder is not equal to a physiologically normal bladder, which I will show with some examples later in the talk. So radiation therapy is very important, and COG STS also says that radiation is important for all patients of CG2 to CG4. Only clinical group 1, which means completely resected tumors with microscopically negative margins, are ones in which we can try without chemotherapy. While PSYOP has been trying to treat these patients more and more without giving radiotherapy, and those who achieve complete response to chemotherapy do not get radiotherapy, but their outcomes are not as good as the COG groups. Now, I will use 2 examples to highlight what I have said just now. So this is a story of an 18-year-old girl who presented to us with abdominal distension, with severe pain, and there was no hematuria or discharge. There was mild constipation and no rectal bleeding. She was pale, irritable. She had a huge hypoglycemic mass with a smooth surface, irregular margin, and lower limit could not be defined, and the perineum was normal in this child. Rectal examination showed that it was a mass arising anteriorly to the rectum, probably from the bladder or the uterus. So these are the CT scans, which shows very clearly that the mass is arising from the dome of the bladder. Here you can see it is arising from the dome of the bladder. It was a large mass, and there was mild hydronephrosis on one side, and the metastatic workup in this child was normal. So this child, because it was arising from the dome of the bladder and had a lot of pain, went upfront resection, including the dome of the bladder, and the histology surprisingly came out as spindle cell RMS. So this child had a spindle cell RMS of the bladder dome with microscopic negative margins and lymph node negative. Now, how do we stage this patient? So we stage this patient. This is obviously clinical group 1 because complete resection without microscopic positive margins. TNM staging, unfavorable sites, larger than 5 centimeters, but lymph node negative, it becomes stage 3. And in the risk categorization, it becomes low risk B because TNM3, CG1, unfavorable site becomes a low risk tumor. How do we treat this patient? So final diagnosis is spindle cell embryonal rhabdomyosarcoma of the bladder dome, CG1A, stage 3, low risk B. This is how we are supposed to stage these patients. And if we stage these patients according to international staging system, then the results can be compared with various studies. Otherwise, it becomes very difficult to compare the outcomes. So these patients is treated with VAC for 42 weeks and no radiotherapy because the margins were negative. So this is the story of this patient. She got 42 weeks of chemotherapy, no radiotherapy, and follow-up with routine radiology was good. She was disease-free at 5 years, but complained of the frequency of micturition. And this was in 2016. So we advised various investigations, including the MCU, ultrasound, and neurodynamics. The MCU revealed a small capacity bladder with no reflux and no PVR. And ultrasound was normal, no hydronephrosis. The urodynamic study was alarming because the maximum cystometric capacity was only 39 ml. And she had a low capacity, poor compliance, high pressure system with no uninhibited contraction. So this is to highlight that even though we have preserved, the child is survived, even though we have preserved the bladder, the future doesn't look very good for this patient because it's a poor compliance bladder, and ultimately we know that in due course of time the upper tracts will pack off unless something is done to this patient. So the patient was put on oxybutynin and is being followed up with these. But again, the question again comes same thing. We will have to augment this bladder to decrease the pressure. And if we augment the bladder and give a mitraphanostoma or without a stoma, the scenario is same what the parents didn't want in the first place. They didn't want a resection. For most bladder prostate, this is a dome, but for most bladder prostate, ultimately you will end up with a new bladder because the bladder which you have preserved often doesn't work. This is another case which when came to us was 3-year-old. Now he is, I think, 22 years old with abdominal distension, lump, hematuria, strangury, and dysuria. So this was a bladder base prostate RMS, which you can see on the MCU here and the ultrasound here, but it was metastatic. You see multiple nodules here. So this patient, this is a CT scan showing a large tumor in the bladder base. The core needle biopsy proved it to be embryonal rhabdomyosarcoma of the botryoid variety, and the metastatic workup, we have already seen the lungs were positive. So staging clinical group 4 because it is metastatic, TNM stage 4 because it is metastatic, and risk high because it is stage 4 and CG4. So the chances of survival is less than 35%. Ultimate diagnosis, embryonal rhabdomyosarcoma, CG4, stage 4, high risk. So what do we manage? Again, so this patient is not fit for upfront resection. So these kind of patients are managed with neoadjuvant chemotherapy. So VAC was given for 9 weeks. At 9 weeks, there was good response, and we thought we could resect the patient. When we explained to the parents because of the location that he may lose the bladder and usually the connection with the urethra, and that he will need a mitraphanostoma for life for drainage, they refused surgery. And so we are left with no other option than to continue chemotherapy and give radiotherapy. And this is often the scenario in most of our patients. Either they will abscond at that time and not come back for the further therapy and drop treatment, or they will refuse surgery and say कि आप इसके अलावा कुछ भी कर लो. So that is what happens. But anyway, this patient refused surgery. He got external beam radiotherapy of 45 grays and continued the chemotherapy till end. And at the end, he was disease-free. This is the CT scan when he was in CR, and now 21 years of follow-up. He is still disease-free. He is a journalist working, but he has problems. The urodynamics again shows a small capacity, high pressure bladder with significant PVR. He has frequency of micturition, though he's not incontinent. The GFR is only 43 mils. He is azoospermic, and he has low back pain, and the MRI has revealed sacral hypoplasia. So we see the complications of the treatment that we have given to this patient. So the patient is good. He's going around. His quality of life is good at present. It depends on what quality of life measures you're using. But looking at this, again, this patient is going for a tough time. He's going to pack up unless something is done. So to come back again, to highlight again, pelvic exentration is no longer the initial therapy, but still we must know that at least 30 to 35% of the patients in bladder prostate RMS will ultimately need an exentration procedure if we are to make them live. So excision of the residual nodule is very important. I highlighted that in a lot of times there are no viable tumor in that, and radical cystectomy and prostatectomy can be done when required. It could be done in a single stage or could be diverted, and later bladder reconstruction could be done. So finally, the principles of bladder prostate for surgery is bladder preservation without compromising the survival rates, and cystectomy to be resorted to when this fails. I have mentioned some of the side effects, late effects. There's delayed puberty. Often the patients are incontinent, or they have dribbling, or they have frequency, and they have small capacity, high pressure systems. Upper tract deterioration slowly takes place, which we have to take care. And unfortunately, a lot of these patients are being taken care of by the medical oncologist or the pediatric oncologist. They do not realize the outcome of this from the bladder side. So they never investigate the patient for doing a urodynamics or looking at the upper tracts. They are looking at only the oncology. So there's no recurrence and they are very happy. So that is the problem so I think we are better placed as pediatric surgeons to take care of these patients. Second malignancy is also a problem in these patients. Now, some small results from our studies here. This was a paper presented in Toronto in SIO of 41 patients of bladder prostate RMS. And we are evaluating the necessity for surgery as local therapy in rhabdomyosarcoma. So we have been questioning whether actually surgery is required, or can we achieve the same outcomes without, actually doing major bladder surgeries. And we found that the overall survival and event-free survival was not different whether you operated the patient or you did not operate the patient. So this is the take recently done work, and in which 41 bladder prostate RMS were initially seen that we have treated, out of which 34 were evaluable, 7 not evaluable because of early deaths in either at the time of admission only or during the first course, and long-term follow-ups were there in 19 patients. Of these, only 3 had undergone resection. That means 16% had undergone resection, while 16 patients, 84%, had achieved a CR without bladder resection with chemotherapy and radiotherapy. And but I have already highlighted the problems that we face in the long term. So of these 19 patients, only 5 patients, 1/4 of them, did not have any urinary symptoms. 3/4 of them had urinary symptoms. 1 had to be augmented, and 6 are on oxybutylene or imipramine, and the others are on follow-up. But they will need something sooner or later. The follow-up period is long. Median follow-up is 9 years. And median onset of symptoms is around 4 years. So it is necessary to follow them up for a long period of time to actually catch them. And we have to investigate these patients again and again because the scenario keeps changing if we want to preserve their upper tracts. So urinary symptoms are in terms of incontinence, dribbling, or high pressure system, falling GFR. Sometimes they present with hematuria. We know cyclophosphamide effect on the bladder, and second malignancy also. Girls present with amenorrhea, and low backache is common, especially because of the radiotherapy, and azoospermia is there for all. The ovarian follicles are slightly more resistant, but the sperms, they become all azoospermic. So this is one of the studies which is now being done, whether we can reduce the dose from 2.2 grams of cyclophosphamide to 1.2 grams, which has already been done, but the outcomes are awaited, whether that will help in this aspect of azoospermia. Thank you, Asian Association of Pediatric Urology, for giving me this opportunity.
Thank you, sir, for the enlightening talk. We shall now proceed to the Indian Society of Pediatric Urology lecture for this year. And for that, I would like to invite Dr. Devendra Kumar Yadav, sir. He's an additional professor in Department of Pediatric Surgery, All India Institute of Medical Sciences, New Delhi. Sir is a graduate from GSVM Kanpur and has completed his MS General Surgery from KGMC Lucknow. He's a pediatric surgery alumnus of AIIMS and has worked in the Department of Pediatric Surgery, VMMC, Safdarjung for 6 years. Sir is also a member of National Board of Examinations for Pediatric Surgery and has been secretary of Delhi chapter of IAPS from 2014 to 2018. He has more than 50 publications in various national and international journals and has a keen interest in reconstructive surgery and surgical oncology. Sir is a recipient of SIOP scholarship thrice and is a national level quiz awardee in 2004 for general surgery and in pediatric surgery in the year 2007. Sir is well known for his enthusiasm in teaching and in resident training. Sir will now be delivering the ISPO lecture on current updates on the management of Wilms tumor. Over to you, sir.
We now invite Dr. Yadav and Professor Bajpai and Professor Mitra to give the award to Dr. Yadav.
शेयर हो रहा है इसको स्लाइड शो लगा दो Good evening to one and all, and at the outset I would like to thanks Professor Bajpai for giving me the opportunity to present lecture on for the Indian Society for Pediatric Urology. And I will emphasize that at the time of my training, I completed my both thesis on Wilms tumor. One was tumor infiltrating lymphocytes, and another was the telomerase activity in Wilms tumor under Professor Bajpai and Dr. Sandeep Agrawala. Thanks, sir, for guiding me, and now I am proceeding this work. As we know, the Wilms tumor accounts for more than 5% of the total pediatric malignancy, and in this 80% of the tumor are mostly Wilms tumor. For the better outcome in Wilms tumor and to decrease the toxicity of various drugs, two major cooperative trials, COG and SIOP, were established way back in 1969. Initially, only stage was considered as a prognostic factor, but gradually, as the science and knowledge improve, the various drugs come into the picture, and prognosis of this tumor way back in 1970s were around 50%, and nowadays both the group SIOP and COG has survival more than 90%. Although the philosophy of management is different in both the group, but overall survival and outcome is the same. So it's depend upon how you choose these protocol for the management of the patients. In 2018 also, the WHO launched the Global Initiative for the Childhood Cancer. The philosophy, how the philosophy of SIOP and COG is different. It's depend on different stratification, different staging system. Role of biopsy is also different in both the group. While the preoperative chemotherapy, the indication for preoperative chemotherapy, while in SIOP, always preoperative chemotherapy, especially in children age less than 6 months, or sometimes if age of presentation is more than 10 years. Mostly post-operative chemotherapy is different. The bilateral, for the cases of bilateral tumors and for the stage 4 tumor, the treatment option is different. Overall survival for stage 1 and stage 3 in both the stream in SIOP and COG almost same, but for the stage 4 disease, the COG protocol outcome is slightly better than the SIOP protocol. The staging of Wilms tumor usually in COG protocol, when the tumor is as a broad staging, when the tumor is confined to the kidney, it's stage 1. When the tumor is beyond the kidney but resectable, is stage 2. And if there is a locally extensive tumor, means there is lymph node positive, or there is spillage, or there is gross residue, then is stage 4. And metastatic stage stage 3, metastatic is stage 4, and bilateral tumors is stage 5. This in NWTS 5, any spillage, whether preoperative, this is called rupture, and in intraoperative, this is called spillage, is considered as stage 3. And treatment of the stage 4 depend upon the response to the chemotherapy, and further this is local staging done separately. The in COG protocol, the risk stratification was done based on the favorable histology tumor or unfavorable histology tumor. Unfavorable histology means presence of anaplasia. Rest of the tumor are of favorable histology. The COG protocol gradually includes the loss of heterozygosity for 1p and 16q. This data was started from 2017 till 2007 to 2013 and freezes in 2016. Loss of LOH at 1p is found in 11% of the cases, and at 16q is found in 20% of the cases. And when there is expression of both 1p and 16q, the event-free survivals is 84% if there is no loss of LOH, and 5-year overall survival is more than 95% in cases when there is no LOH. But if LOH is present, both event-free survival and overall survival is affected. That's why in the current COG protocol, this was LOH at 1p and 16q was included. For stage 4 Wilms tumor, the response was assessed as a complete response, incomplete response, and some stable disease. The rapid response is defined as the complete resolution of lung metastasis at 6 weeks after the chemotherapy. And slow responder, there is metastatic nodule present beyond the 6 weeks. In risk stratification for the favorable histology Wilms tumor, the treatment is based on the risk. The risk is defined very low risk group, standard, and high risk group. For very low risk group, there is 2 group. In one, when the age is less than 2 years, tumor weight is less than 550 grams, and there is this is considered as stage 1 favorable histology Wilms tumor. Another is low risk group when there is no LOH, and standard risk group when there is LOH is present, loss 1p and 16q. For this, DD4A chemotherapy protocol is used, and for the high risk group, regimen M is used. E4A given for 18 weeks, DD4A for the 25 weeks, And the regime consists 6 weeks, same as the DD4A. After then, 4 courses of cyclophosphamide and etoposide given. In favorable histology Wilms tumor, the first generation risk stratification by children oncology group. How we identify the literature having first generation of risk stratification is these all the this risk group study started with the 0, ARAN 0 for the stage 1 favorable histology, and in children having age less than 2 years, tumor weight less than 550 gram, only total 66% were included in this series. In this series, there was event-free survival was around 88%, overall survival was 100%. But there is low number of patients in this group because of the parental concern. There is low accrual rate. But when the post hoc analysis of these data shows that the stage 1 tumor, age less than 2 years, weight less than 550 gram, if this tumor is epithelial predominant, the overall survival is 100%, but event-free survival increases from 85% to 96%. So that's why in the future COG study, the COG is trying to include this as a separate group. Another COG protocol, ARIN 0533 for the stage 3 favorable histology Wilms tumor with LOH, and stage 4 favorable histology Wilms tumor. ARIN 0534 is for the bilateral Wilms tumor and diffuse hyperplastic perilobar nephroblastoma, and ARIN 0321 is for the focal and anaplastic, focal and diffuse anaplastic Wilms tumor and clear cell sarcoma, malignant tumor, and the renal cell carcinoma. I have discussed the management of stage 2 and stage 1 and stage 2 focal favorable histology Wilms tumor. If there is no LOH present except very low risk group, the surgery followed by E4 regime, no radiotherapy is required. But if there is presence of loss of heterozygosity, this all the patient is treated with DD4A regime. And if there is stage 3, then the local radiotherapy is required. In cases of stage 3 favorable histology Wilms tumor, if there is loss of heterozygosity, then all these patients were treated with regimen M and then local radiotherapy depending upon the local condition. If there is no spillage, then flank radiation is given, and if spillage is present, whole abdomen radiation is required in all these cases. For the stage 4 Wilms tumor, if there is rapid response and there is no loss of heterozygosity, local radiotherapy to the lung may be avoided, and local radiotherapies depend upon the local staging. If the stage 3, radiotherapy for the bed may be needed. If there is loss of heterozygosity, then surgery and followed by chemotherapy regime and protocol, two additional drugs. And again, in these all cases required pulmonary radiation, and the local therapy depend upon the local staging. For the anaplasia, at present COG protocol, stage 1 diffuse and focal anaplasia needed required DD4A regime with flank radiation. But whether this flank radiation improvement in survival because of this flank radiation is due to addition of doxorubicin or because of the radiotherapy. The further COG is study has been is ongoing study is there, whether we should include this radiotherapy in stage 1 diffuse or focal anaplasia cases, radiotherapy should be given or not. But at present, for stage 1 disease, for stage 1 and onward, they are giving the radiotherapy to the local bed. In cases of SIOP, mostly the risk categorization is dependent on the post-operative histology. And this histology is identified, categorized into low, intermediate, and high risk, depending upon the pathology. That's why in the if we are adapting the SIOP protocol, the pathologist must be from the central institution, because the pathology is very difficult to interpret, because the whole of the treatment depends upon the types of the pathology, and on this basis we categorize this tumor as a low, intermediate, and high risk. For tumor, if the tumor volume is more than 500 ml, in these cases the event-free survival and overall survival is affected. That's why the tumor volume is also included in the risk stratification of SIOP protocol. For stage 4 tumors, the treatment strategy for as per the SIOP protocol is little bit difficult, and depending upon the local stages and other pathological changes, the therapy is decided. Now, one important factor which we always remember, in treatment process of Wilms tumor, the surgeon always play an important role, because some factor like tumor biology can't be altered. But if the surgeon is not fully committed with the treatment of Wilms tumor, how to do the surgery, the staging will always be upgraded. And if there is chance, if there is tumor spillage, the overall, if the event-free survival and overall survival is affected. That's why the proper surgical protocol should be followed. And this that's why in the NWTS 5 they adopted a proper surgical chart for staging the disease. The usually in COG protocol, the upfront surgery is done. Some cases require preoperative chemotherapy. The indication for preoperative chemotherapy in COG protocol in cases of bilateral Wilms tumor, solitary kidney with Wilms tumor, Harso kidney with the involvement of the isthmus. There is extension into the IVC beyond the hepatic veins, and there is involvement of contiguous organ. And there is, in cases of stage 4 disease, there is the respiratory compromise because of the extensive metastasis. Usually in SIOP protocol, all the cases treated with only 2 drugs for the 4 week, and in stage 4, in cases of stage 4 tumor, 6-week chemotherapy has been given, including the doxorubicin. Now, how to assess the response, how to assess the response to the neoadjuvant therapies depend upon the tumor radiology. For the proper assessment of whether this tumor contain any nephrogenic rest or not, very difficult to identify with the CT scan. But MRI is helpful in most of the cases to identify the nephrogenic rest. The role of ultrasonography in cases of IVC thrombus, as per the COG protocol, if the patient is already having proper contrast enhanced CT scan, and if we are able to identify all of the IVC and renal vein, then Doppler study is not required. But in our scenario, most of the tumor presented with large mass, IVC is compressed, renal vein is compressed, so we can't, there may be difficulty to identify the whole of the IVC. In these cases, the color Doppler investigation is required, whether we can identify whether this IVC portion is having flow or not. If there is no flow, then there are chances of having IVC thrombus. Now, how we assess at up to which week we should give this preoperative chemotherapy? With the help of preoperative chemotherapy, usually more than 50% of the IVC thrombus become non-viable. But the responses in cases of IVC thrombus and renal well thrombus, usually after 6 to 8 weeks, there is no whatever response is going to happen, it will occur within 6 weeks. beyond 6 to 8 weeks, no further chemotherapy will be helpful and surgery will be needed. What will the causes of non-responses of neoadjuvant therapy? This will, in cases of necrotic tumor, because of hydronephrosis, and there is actual non-response because of the stromal predominant histology, and sometimes the tumors may be other than the Wilms tumor, like anaplastic and the presence of anaplasia, clear cell sarcoma, or the tumor of the kidney. The surgical approach gold standard is the flank of approach, intraperitoneal approach. Laparoscopy, though in our department have experience of operating more than 20 cases of Wilms tumor with almost 90% of event-free survival, but the number of cases is minimal. Professor Bajpayee used to operate these smaller Wilms tumor with the help of laparoscopy. Usually laparoscopy, as per COG guideline, they don't recommend for the laparoscopic resection of the tumor, but in the some of the participants from the SIO, they advocate the laparoscopic resection, especially in the polar tumor. The tumor size is less than 3 centimeter, and if we are sure that the we can in that cases the tumor histology, the lymph node sampling may be done adequately. But in most of the cases, with the use of laparoscopy, the adequate lymph node sampling is difficult, because lymph node sampling is very important. Most of the time, even if this IVC thrombus or renal vein thrombus can be identified with the help of CT scan, but the palpation by the surgeon of that renal vein and IVC is necessary. Even if sometimes the investigation, these radiological investigation may not identify the renal vein and IVC thrombus. In case, what will happen in if you are not able to adequately sample the lymph node? We have to know the draining area for the kidney. The draining lymph node area for the kidney is below the renal hilum. So at least what should be the number there? There is no concern with the number of lymph node sampling. The main important is there is a station where these renal vein, the renal lymphatic drain, and at least we should all the 7 stations should be included in the sampling. But as per the COG protocol and SIO criteria, the average number of lymph nodes sampled in SIO protocol was 3. In NW in COG protocol was 5. But on the basis of lymph node sampling and lymph node ill, the COG said that if lymph node ill is more than 0.38, in these cases, the overall, this may predict the overall survival and event-free survival. For the lymph node sampling, the National Cancer Database identified 2,340 patients, and all these patients who have the lymph node density of more than 0.38, the overall survival and event-free survival. This was helpful in determining the overall survival and event-free survival. In COG group, any biopsy will upstage the tumor. It is very difficult to identify the pre-op rupture. There are some signs on the basis of it, like in the retroperitoneal hemorrhage, presence of ascites, pre-operative, there is fat stranding around the tumor. This may be helpful in identification of pre-operative rupture, but all this pre-operative rupture must be confirmed by the surgery, not on the basis of the radiological investigation. And if you are not able to remove the tumor in as a whole, again this will consider as a spill, and the stage become local stage 3. In risk of recurrence after spillage is more, and most of the time we should avoid this spillage, because if there is spillage, we have to add doxorubicin. There will be addition of whole abdomen irradiation, and longer duration of treatment is required. For IVC and renal vein extension, it ranges from 4.8 8 to 11.3% cases. And I have discussed all these cases. If in our institute, if any degree of involvement of IVC and renal well with the IVC thrombus, we start preoperative chemotherapy. But these thrombus, in 50% of the cases, the thrombus become non-viable, and we can easily take out the thrombus. But sometimes, if there is extension of thrombus beyond the superior hepatic vein and into the atria, then the cardiopulmonary bypass may be required. The role of nephron sparing surgery is discussed well in the SIOP protocol. In COG protocol, nephron sparing surgery is useful in cases of bilateral Wilms tumor, because we have concern there is concern of hyperfiltration injury, and there is chances of having decreased GFR with the one kidney. In COG protocol, the absolute indication of nephron sparing surgery is solitary kidney. There is predisposition to if there is chances of having bilateral tumors. In cases of horseshoe kidney, if there is involvement of isthmus, and in cases of Denny-Dias or Frazier syndrome. The relative indication for the nephron sparing surgery is the associated hypospadias and undescended testis, and there is the Weger syndrome and tuberous sclerosis. The treatment option for nephron sparing surgery is the partial nephrectomy, atypical segmental resection, heminephrectomy, either longitudinal or horizontal. There is tumor enucleation, and there is ex vivo resection with auto transplantation. For the bilateral Wilms tumor, arrange 0534 study group was preoperative chemotherapy, and they assess the response of chemotherapy after 3 weeks by the RECIST criteria 1. With this criteria, if there is response is more than 30%, they again give chemotherapy by further 3 weeks, and at 6 weeks they again assess the response. If there is more than 50% response, the tumor is considered as responsive. But if there is no response, as I have told earlier, the causes are poor response to the preoperative chemotherapy. In another area in which our department has worked way back in 2007, the immune responses in cases of Wilms tumor. The immune, sometimes the body immunity plays an important role in identifying the tumor and destroying it. The immune cell infiltration, tissue activated macrophages, M2 and M1 found, and if there is more infiltration of M2, there is more chances of having more locally aggressive tumor. And in almost all of the cases of Wilms tumor have CD3 infiltration. These expression of immune checkpoint molecules like PD-L1, if PD-L1 is expressed into the on the basis of immunohistochemistry, the chances of survival is poor. Whether this PD-L1 expression is correlated with the established prognostic factor in COG protocol, like loss of heterozygosity 1P or 16Q or not. So we are assessing this in our department, whether this PD-L1 expression is associated with loss of heterozygosity 1P or 16Q or not. Another important aspect is loss 1Q gain. In COG protocol, at present, all the COG protocol, they are not including the gain of 1Q. But the importance of 1Q gain is that 1Q gain is identified in around 30% of the cases. And especially in cases of stage 4 tumors, in rapid responder, where the 1Q gain was present, if 1Q gain was present in rapid responder, lung radiotherapy was not given in that cases, the event-free survival rate was only 57%. That's why COG is again assessing and advocated that if you are not having the facility of facility for the identification of 1P and 16Q loss of heterozygosity, I think we should wait for to follow these chemotherapy protocol. Now the future goal of COG study is how to 1Q gain can be used in cases of favorable histology Wilms tumor, and loss of heterozygosity in cases of stage 1 febrile histology tumor, because in tumor, very low risk group tumor, if there is loss of imprinting or loss of heterozygosity of 11p15, the event-free survival drastically decrease by more than 20% cases. That's why they are again assessing this, whether we should use this or not. Then again, both the COG and SIOP started way back in 1965, but philosophy was different. But now in COG is also assessing the role of post chemotherapy histology changes, how these histology changes can be included in the risk stratification, and in some stage 3 cases, how the doxorubicin can be emitted. And in cases of radiotherapy, the cardiac sparing intensity modulated lung radiotherapy is now being tried. Thank you.
Thank you, sir, for an enlightening presentation. I now hand over the platform to Dr. Ajay Verma, sir, who will be coordinating the felicitation function.
Good evening, everyone. We welcome you to this felicitation function. We are grateful to present this year's Asian Society of Pediatric Urology and Indian Society of Pediatric Urology Lifetime Achievement Award to Professor D.K. Mitra. Professor D.K. Mitra completed his MCH in pediatric surgery from this institute and joined as faculty in 1974. He later became head of the department in 1994 and served the department till December 2004. He has been awarded the Commonwealth Fellowship, the membership of National Academy of Medical Sciences, and the Lifetime Achievement Award from Indian Association of Pediatric Surgeons. Dr. Mitra has been a grassroots level worker, always emphasizing on patient care, research, and training. He is known to be a tough taskmaster. He is highly respected as pediatric surgeon and held in high regard by the department's ex-student and also the entire pediatric surgical community of our country. His contributions to the development of Department of Pediatric Surgery at AIIMS New Delhi were immense and would always be remembered. I invite Professor Sandeep Agarwala to share some of his memories through vintage photographs.
So I present a few pictures that I've managed to collect in this short period of time. So as Ajay mentioned, Dr. Mitra has been with us for a very long time, and we celebrate his 80th birthday today and felicitate him from the Indian and Asian Association of Pediatric Surgeons. And as we all know, behind a successful man, there is always a successful woman. And unfortunately, Mrs. Mitra could not come today, but these are some recent photographs still at this age, enjoying life. And you'll be surprised to know that he still operates sometimes when he's called upon, not regularly, and he's very active. These are some of the old pictures. This is 1987, probably from the time that Dr. Upadhyay was retiring. And these are some of the pictures of various conferences which were organized in those days in 80s and early 90s. This is one of the few pictures that I have of 1994, the year that I joined as a faculty. And this was with the visitor. And you can see Dr. Gupta, Dr. Bhatnagar, and myself and Dr. Mitra there with Raman and Anindya there in this picture. This was in 2002 in the esophageal surgery workshop which Dr. Gupta had organized, and Dr. Mitra was there for that also. And this is the farewell party of Dr. Mitra in 2004, where he was felicitated by a large number of people, both staff, students, residents, and also some of the older staff which are there. The hall with a lot of people who are there now, Some of these can be seen in this picture here. And this was the farewell picture of Dr. Mitra. And these are some of my personal trips with Dr. Mitra, my family and his family, and with Dr. Chatterjee also, who is also a retired professor of GI surgery in this. So we thank you, sir, for all that you have done for us and the department. And we look forward to moving ahead in this new building, which you see here. Thank you.
I invite Professor D.K. Mitra as guest of honor for today's felicitation function. I also invite Professor Bajpai to felicitate the guest of honor.
They request all the residents to please come. So they can have a round of introduction to scholars. रोक के सारी बता दीजिए
Sir, on कर लीजिए.
For telling me that I'm old.
Old memories.
Sir, I have a very long relationship with Professor Mitra. I joined All India Institute from Safdarjung in 1976 as MCH candidate. At that time, Dr. Mitra has just joined as a faculty. So since then, and then my continuation with him is both professionally as well as family. His son and my son were together in the school, and they both did engineering. They both have went to US. So, I mean, I really respect him like as an elder brother. This is the least I can say. Thank you.
Namaskar, sir. Well, sir was kind enough to accept me into the department after he returned from Afghanistan. And I spent for about 4.5 years with him. I was Professor Rodki's student, but sir taught me how to run a department. That is a fact. And that is why I was able to do very little in RML and start and run a department. I definitely owe it to him. And being a disciplinarian and a perfectionist, both during surgery and also during academic sessions, went a long way in making us learn. That is a fact. He's saying yes to everything I'm saying, so I must be saying something right.
I have done the same.
Absolutely. Thank you.
Thank you.
I have lots of stories.
I'm sure you do.
But I must tell you that I met Sir when I was 22 years old. He may not remember, but I came as an intern in my externship to the Department of Pediatric Surgery, and I was hooked from day one. And however young I was and however unbridled my energy was, Dr. D.K. Mitra, I will say, sir, you have been my biggest inspiration.
Thank you.
Sir has been the person who taught me many things which he also may not know. But one of the things was his keen sense of observation.
No, I must know. That is why.
Keen sense of observation. So keen sense of observation, the ability to see beyond what everybody else sees. The ability to notice small things, small details, which I think has really helped me in my career, for which I will be eternally grateful to sir. Apart from all of that, sir must have thought, I don't know, this crazy kid, I don't know whether she last or whatever it is, I cannot tell you. I was one of the few students who stayed in the 5-year plus one. A lot of people before me and after me left, but I persisted because I was so amazed by the quality of surgeries that was being performed by the department. Each person, par excellence, I say it again, I have never seen better hands than the people that I've seen before me. I have my very good friend and my soul brother, Srinivas, who's doing a brilliant job in Hyderabad. I'll speak for him because he used to constantly tease me as saying, you were Lama, left against Mitra's advice. And he used to constantly also tell me, which I said before, is like teacher, you are the student, you will also become like teacher. So he thought he was insulting me, but I take it as the biggest blessing and I'm so grateful, sir.
Thank you.
You can pass it on to him.
I am Dr. Nisar. I was doing my MSc from 1999. I finished it in 2002 January, because I had joined 15 days late. So presently I am heading the pediatric surgery at Sher Kashmir Institute of Medical Sciences, where we have a MSc program in progress. Yearly we take 2 candidates. Yeah, we have a very good, I have a very good team, very energetic and very honest team with me. And I was a little unfortunately not to spend any time with the Professor Mitra, because during that time he was on overseas this job. But my relief from this place, he had to sign my papers. That day he had already returned. But I had the opportunity to work him, the same place where I had to share my roster with him. Though I was feeling uncomfortable in sharing the roster, but I had a lot of things to, learn from him. I wish him a good health. Thank you very much, sir.
Thank you.
I am Dr. Anand Reddy. I am right now heading the Department of Pediatric Surgery in Bangalore Medical College. I did my MCH between 95 and 98. And the building, you may do whatever of cosmesis on the outside. You can have multiple stories of building and everything. Finally, what makes the building strong is the foundation. And my foundation as a pediatric surgeon is definitely Professor D.K. Mitra. I am what I am. My basic foundation is because of sir. And of course, all the other teachers have helped in building me up to what I am. He's already, I think in the beginning, somebody said, a taskmaster. Yes, taskmaster when patient care is concerned. There are lots of things which I picked up from him, whom to trust during rounds, whether the resident or the mother, what to focus on. Monitors working, not working. We will all be looking at rounds and presenting our cases, but he will be looking at the monitor. Monitor nature, what's happening? How are you monitoring the patients? And lots of things. Yes, I mean, it's very difficult to keep enumerating suddenly. But at the same time, he always used to have personal touch with respect to each and every student, know about their family, any troubles they are facing, any help which is required, and always made sure that we were comfortable during a residency. Being a stern taskmaster is part and parcel of every teacher, but at the same time, making sure that you did your work, any difficulties you faced were always taken care of. We could always go to him with personal problems and get his advice on that. Thank you, sir. Very much.
Thank you.
So I'm Satish Agarwal. I was an MCH student at All India Institute between 1989 and 92. And sir, many congratulations on your birthday today. I didn't know initially, but many congratulations to you, sir.
Thank you.
I remember you and I'll always remember you as a teacher par excellence, as a human being par excellence, and as a teacher of human values while taking care of the patients. Some of the words that I remember from the rounds that you used to tell us, which still are with me and with my now students. You taught us that howsoever good clinician you may become, the mother is the biggest clinician. If a child is brought to emergency in the middle of the night and your assessment says that there is nothing wrong with the child, ask the mother, क्या आपको बच्चा ठीक लगता है? अगर माँ कहती है कि नहीं कुछ गड़बड़ है, तो गड़बड़ है. Or these words always used to be true. You also taught us how to be compassionate with the family. I remember those days we didn't like it because we were students, we were working under odd circumstances. But you used to scold us. कि तुमने इससे कैनोला क्यों खरीदवाया? तुमने 2 कैनोले वेस्ट कर दिए. तुमने सोचा इसके पास पैसे खाने के लिए नहीं है, कैनोला लाएगा. So those are the kind of things that you, while treating patients, you are looking into their socio-economic background, their compulsions, their problems, especially the mother. So those are the values that you have taught us. You're a very hard taskmaster, and I'm thankful that I had a hard taskmaster like Dr. Mitra as my teacher. And like so many of us, we remember you that way. You had an inclination to recognize somebody's strengths and weaknesses and work on them. You would know when to give surgery to a resident, how to give surgery to a resident. And all of us remember that you used to guide us from behind. Lamba aujar do, yahan pe kaato, idhar kaato, piche se. So standing on your shoulder, you used to guide us into doing even complex surgeries. That's what makes him Dr. Mitra. A class apart. Thank you so much, sir, for guiding us.
I just wanted to add one thing when you're talking about surgery. I remember my first laminectomy and detethering in my early second year, private ward patient. You didn't scrub, and that was my first case I was doing. You standing behind and directed me. I'm proud to say that I continued doing, one of very few who continue doing occult spinal dysraphism, and just last month I finished 120 of detethering in the last 6-8 years. Quite a large series. It was published also in the JAPS 3 years back.
And in fact, I owe to you, sir, my posting in Maulana Azad. When I finished my MCH from here, I had done my MS from Maulana Azad and MBBS also from Maulana Azad. He was instrumental in getting a place for me as a faculty in Maulana Azad. Right on day 1, I resigned from here. I completed my tenure in the morning, and in the evening, I joined Maulana Azad as a faculty, all because of Dr. Mitra's efforts. He made personal efforts to find a place for me in Maulana Azad. I stayed in Maulana Azad for nearly 25 years, reached head of the department's position, and then I took VRS in 2016. And since then, I'm at Sir Gangaram Hospital with Professor Kulsheshta. Thank you, sir.
I'm Dr. Samir Acharya from Safdarjung Hospital. Sir is a great teacher and mentor, and he always have a loving attitude towards his students. And till today, he remember all his students and always have a loving attitude, and I really admire that. Thank you.
I am Viral Luthra. I was here between 83 and 86. And Meenu and I and Anurag Krishna, we overlapped at the same time, including Prashant. So everybody's saying is good things, okay? We had fights with Dr. Mitra. Straight on. Aisa nahi hai. We got shouted at, but we also learned, but we reasoned with him. So it was all part of the game. And I think it was all part of growing up. And also we learned that if he's teaching you and you were there and you went away, you better not say every time you don't know how to do this. Can you be around? Because he had a short fuse. So I mean it well, I don't mean it, but I think we learned a lot in the department. And in the same line, Dr. Mitra's birthday today, but we learned different things from Dr. Upadhyaya and different things from Dr. Rodgi and from Dr. Mitra and equally different things from Viresh. So I think if you actually want to catch, you catch the best out of everybody. And you will ultimately make your own journey. So thank you, Dr. Mitra.
Thank you.
I'm Rajiv Chadda from Kalavati. I would really endorse what everybody said. I remember sir as an excellent surgeon, an excellent teacher, and above all, I think as a very good human being. As Satish himself mentioned, in a way, actually, he used to work almost as hard as any resident, and his focus was on patient care. And I remember once I was rude with the patient, and very kindly he told me that you don't talk to patients like this. And the other thing which I remember is that he used to especially care for the poor patients and the fact that they wouldn't be having the money to buy the stuff and to stay there. And the other memory which, in addition to all the things that we were taught and of learning surgery and everything from him was, I remember sitting in the OPD with him, he would be there even before us. And I remember I once said, sir, मैं form भर देता हूँ. And he said very angrily, नहीं मैंने patient देखा है मैं form भरूँगा. And that's something that has stayed in my mind. You have seen a patient, you fill up the form, the other person does his own job. So all his focus was on patient care, the residents, and teaching us. There was no ego involved really. I mean, it was all for the patients and especially for the poor patients. And that was a life lesson that you do your own work, you take care of the poor patients, and you work as hard as the residents. So this is something which you learn very, very rarely, and I really indebted to Dr. Mitra for that.
है ना, आपने मुझे आईवी लाइन के लिए एक दिन बहुत डांट पड़ी थी. उस दिन मैं ये भी बुला रहे हो, अब नए नए जनरल सर्जरी इफ यू कम फ्रॉम, हाउ डू यू नो हाउ टू पुट एन आईवी लाइन इन द बेबी. उसके बाद मैंने कहा मैं अब व्हाट टू डू, कांट गेट इट, डू आई डू अ कट डाउन? नो, आई सेड ओके. So anyway, he had to come after that day, and next day then I put out the pediatric colleagues. But आज तक उसका असर ये है कि the anesthetists don't get a line, I get it, which is what we got from Dr. Mitra.
Myself, Mohammed Kumar Mante, actually working at Bhubaneswar as professor. So when I joined in 2000, sir was in a sabbatical leave. So after 1 year, I think sir joined back. So there was talk in the department, sir is a very hard taskmaster. Still, I remember, sir, your grand round on Thursday. Fortunately, I was doing all the Wednesday duty. So that Thursday grand round was really so I pray to Lord Jagannath to keep you in good health, sir. Thank you, sir.
Thank you.
I am Manish Pathak. I am working as additional professor at AIMS Jodhpur. I joined AIMS in 2002, and I was there till 2007. I remember sir as for his discipline, honesty, and integrity, and his caring nature. Means when I used to come to the OPD after doing the night duty, used to ask me कुछ खाया, तो मैं थोड़ी देर चुप रहता था. इसने कुछ नहीं खाया होगा, जाओ पहले खाना खा के जाओ. अरे संदीप ये मर जाएगा, कुछ खाता नहीं है. तो sir used to take care. Means we remember you fondly, sir, and thank you, sir, for everything.
I'm Dr. Vivekanand Jindal. I joined here in 2001. When I joined, Dr. Gupta was the HOD. He was very easygoing. When I came from rotation in 2002, Dr. Mitra had come from the sabbatical, and it was a drastic change for me, basically. And somehow that rotation was basically last 1 month, orthopedics rotation especially. Nobody take it seriously. Yeah, I think all the 6-year candidates must agree with that. So I went to Ballabgarh and did some surgeries. Free hand surgery we used to get there. So Wednesday and all some days we used to go there and do some surgeries. So Dr. Mitra got to know, and he when I came back, he gave me a punishment posting with all Friday OT, Friday, I'll be in Dr. Bhatnagar's OT. And as there was very less senior resident at the time, so I was the first assistant to him. And it was a tough job, but it was a blessing in disguise, sir. And sir was very disciplined, as Manish told, and very tough taskmaster. He used to come to the teaching, and whenever the academics used to be there, at 8 o'clock, before 8. And he used to calculate, just keep observation, who is coming what time. Then at the end of month, he said that, what is the scoring point, who is that late? So in one point of time, he told me, you are also nowadays second in the late comers, basically. Thank you, sir, for all the discipline and all the administrative skills, whatever you have given to us. Thank you, sir.
Good evening, sir. Good evening, everybody. Sir, I'm Prabudh. I did my 6-year course from here and right now working as additional professor. I joined after you superannuated. So probably I'm the first resident who joined after you superannuated. And I have never been trained under you, but I have been trained with your stories. So those were the times when I was a junior resident, several days old. And whenever I used to do something wrong, the first line came to me was, तुमको पता है अगर डॉक्टर मित्रा होते तो क्या होता तुम्हारे साथ आज. And so much so that the height of these stories, when I joined as faculty and my current boss Professor Bajpai sir ने एक patient का hemoglobin पूछ लिया, OT में posted था. I should have known that, somehow I skipped. तो तुमको पता है एक बार मैं डॉक्टर मित्रा को राउंड दिला रहा था और मैंने पेशेंट का हीमोग्लोबिन 8.5 बता दिया. He accepted it, round खत्म हो गया, he went out, then he came back in and calling me my name, he said कि उसका 8.5 नहीं 8.7 है. So sir, I have grown with your stories. And in my initial days, जब आपकी बात होती थी तो ऐसा लगता था कि your tenure as head of department was a saga. Dr. Mitra का time होता. Thank you, sir, for being with all of us. Thank you for creating this department, for shaping this department, sir. Thank you very much.
Good evening, sir. So I'm Vishesh. I joined as 6-year candidate in 2003 under Dr. Mitra, and everybody has. I'll reciprocate what everybody has said. He's a very tough taskmaster. Because when I joined, every SR before his rounds, the rounds were taken jointly by Dr. Mitra, Dr. Bhatnagar, Dr. Sandeep. And before his round day, every SR will take the pile. In the end, after dinner and every work is done, he will sit down with the 40 files and try to memorize all the investigation, all the history, because you are not allowed to open the file, come what may. Even the outputs of every NG catheter, latex trophy made in differential output of all the catheters should be there, should have been told by heart. So, sir, I came from MAMC. I was a UG. MAMC is a very open place where you talk very freely with your seniors and SRs. So I came to AIMS. The atmosphere was very professional. And I was the only resident because Dr. Jindal were not meant to get married. So I was the only resident along and was working every day. So one fine day you saw the files, you said, JR workup nahi hai. Chalo Vishesh, 2 दिन के अंदर सारे पेशेंट का वर्कअप करो. And I thought ये डिपार्टमेंट में क्या प्रॉब्लम है यार, मतलब एक बंदा अभी आया है, डेली ड्यूटी कर रहा है. So you realize the importance of these things later, that you were talking my own benefit. Like a resident, it's important for his training to have the history examination and everything for the patient. Another event in the OT, I was the first junior most JR. So OT में 3.5 का AT tube नहीं था. So somebody told me, जाओ विशेष AT tube लेकर आओ. So I changed the clothes, went to AB5 ward, got the tube. Again changed, came to the OT. Then Dr. Mitra came, who got the tube? I said, I got the tube. Why did you get the tube? Go back again, leave it. So मैं कहा यार department गड़बड़ है थोड़ा सा. But then I realized he's stressing the fact that why the tube is not available in the OT. So he's a very good administrator. And within this 6 months, he left such a deep mark on my thinking that even after passing out, I contacted him multiple times for taking advice. And I went to Kalavati after leaving this place, and he was instrumental. I went to his home, said, what should I do? He told me very clear ideas that what do you want in life. Then immediately told you go and speak to Dr. Chadda. I immediately went and spoke to Dr. Chadda and joined within a week in Kalavati. So thank you, sir, for all the guidance. And I'm amazed. Another thing about patient care, sir, one thing that you taught, and is a very important thing, like if you see X-ray bedside, there's a tendency of jumbling up the X-rays, CT scans, and leaving on the bed. So he used to insist that you sort it out, put it in respective folders, and give it to the patient. So that is which shows that how much caring is about the patients. Thank you, sir.
Before we move to Mr. Grover, we have two or three of our colleagues online. Is Dr. Bhatnagar there?
No.
Dr. Srinivas?
Sir, I'm there, sir.
NCK Reddy?
I'm there, sir. I'm there.
I'm there, Vajpayee. I'm there.
Sir, good evening, sir. Welcome.
Thank you. Let me speak. I have to go for an operation after half an hour.
Yes, sir, we can hear you.
Me? Shall I speak?
Yes, please.
Dr. Bajpayee, Professor Mitra, my dearest friend, Dr. Rajiv is there. Nice to see them, all of them. I entered the Alumni Institute in 1978. It was the first theater somebody was doing hydrocephalus for hours and hours and hours. I thought I may not be able to do surgery, pediatric surgery in future. Next day, it so happened, Dr. Mitra was doing the hydrocephalus, that to a revision. Within half an hour, he did it. He is actually, though there were 3 consultants in the department, Professor Mitra was the main pillar of the department. That's how I felt it that time. He was like a working chairman of any major political party. He is a working pediatric surgeon in that Alumni Institute of Medical Sciences, without which I think it would not have got such a good name in my tenure at least. And he is very simple man, down to earth, I can say. Though he scolds occasionally us, we brush it aside because he's not from his heart. And he was, whatever I have learned in pediatric surgery, I'm telling you, whatever I have learned in pediatric surgery, in my tenure there, actually, I must say, after MS, if you do any super specialty, it's only fine tuning. You should have acquired all the basic skills prior to that. If not so, you don't think you will become any good super specialist. Dr. Mitra was responsible for fine tuning of my surgical skills, I can say. He is the best pragmatic pediatric surgeon I have ever seen. I am not saying just because it is a felicitation for him. Actually, it's my habit, like in Vedic culture, when you wake up from the bed, you remember your parents, you remember your teachers. And like a panel, Professor Mitra is one of them. As soon as I wake up at 5:30, when I do something, I always remember him and wish him a good, long life. That's what I always think about it. And you know, the most surprising fact is, when you don't openly love each other like each other, like Ravana and Lord Rama, they really love each other. I think Dr. Mitra and myself is like that. Not in a negative way I'm talking in a positive way I'm talking it. Professor Mitra I always remember him throughout my career till I operate. Only because of him, I'm still able to operate very fast, very meticulous. It's only because of him. Credit goes to him. If somebody says NCK is operating very good, it's not because of me, it's because of my teachers, especially in pediatric surgery, it's because of Mitra. I wish him a long, healthy, safe, meaningful life for him. Incidentally, Professor Mitra was so affectionate to me. His good wishes made him professor much earlier than him. That is the satire part of it. So he is always in my mind, Professor Mitraji. Only because of you, I'm a successful pediatric surgeon here. Wish you all the best. Bajpayee is becoming more and young and dynamic now, manning all the posts. I wish him good luck. Rajiv, Sandeep, my love to you all. My colleagues is there. I've seen all of them. Wish you all the good luck. Professor Mitraji, bye. Have a long innings, successful, much more. Thank you, sir, for giving me an opportunity.
Thank you very much, sir. So kind of you to join. Dr. Srinivas, please welcome.
Sir, good evening, sir. Thank you very much. First of all, happy birthday, Professor Mitra, sir. And thanks to Professor Bajpai and the team, the pediatric surgery team, which has coordinated with this. And I'm sorry, then actually I had booked my tickets, but I had to cancel it because my father-in-law had some surgery. So he's just getting out of the bed. And so I couldn't make it. In fact, Aruna just told me that she wants to come and say sorry to Professor Mitra that we couldn't make it. We were supposed to come to Delhi just to say namaste to sir. And people have talked about that, sir. I think I can just sum up that the discipline and everything has been told by everybody. I think I still remember by the 3 C's, one is that care, the care for not only the patient and to the senior resident as well. I remember if Arun was supposed to be there, he can tell the story that, one of the cold days in the Delhi, then he asked me that, rounds will not continue unless I put on the sweater. So that was the care to the senior resident also. I never used to wear sweaters. So he used to make me that, I will not start the next patient rounds until I go to the hostel. I had to borrow a sweater from one of my neighbors and put on and come back for the rounds. That was the caring nature of Professor Mitra. And compassion they have spoken about, everybody has spoken. And one thing which they have not, I have not heard anybody saying about the corruption. When we are in the administration, we understand whenever I have trouble, I look at him, we follow the path which has been shown by my teachers, especially Dr. Mitra. I think these 3 C's, the care, compassion, and the corruption is something which go a long way for all of us to remember, just synonymous to Professor Mitra. And what Tichan said, Lama, I think I need to rephrase it to Lama now. I think, sir, we are all learning and aspiring to live with Mitra's advice. I rephrase Lama into Tichan Lama's Lama into the learning, aspiring to be Mitra's advice. We are all what we are here, sir.
As per Dr. Mitra. Learning as per Dr. Mitra.
Yes. So I stand by that, living and aspiring with Mitra's advice. We are all living and aspiring to be on your path, sir. And we all owe you, sir. I especially owe you for all the things what we do, whether it is patient care, whether it's a teaching, whether it's a research. You are the person who brought us into the animal experiments. They went a long way for all of us to look into the research and understand the things and all. And one thing which I wanted to say that, his way of administration is something which has helped me a lot to understand here, taking all the people on the board and then, no looking at the corruption or anything like that. That's something which is very important. And with those principles of Professor Mitra and Professor Bhatnagar, we are able to do things over here very well. Thank you once again. Whatever we are here, it's all because of people like Professor Mitra and my teachers who are sitting there. Happy and healthy, long life, sir. Thank you very much. Thanks to everybody.
Thank you, Srinivas. Thank you, Dr. Chandrasekhar.
Yes, sir. Yes, sir. A very good evening. A very good evening, Professor Mitra, sir. Wish you a very, very happy birthday. Special thanks to Dr. Bajpai for organizing this. Now, I joined my MCH, 5-year MCH pediatric surgery in 1995, January. I was just out of my MBBS and then came. And I met Professor Mitra for the first time. And, I was wondering whether I can stay with this department for 5 years with this person heading the department because he appeared to be a very strict taskmaster. Then, of course, it was Srinivas who actually told me that don't worry, he'll look after you.
I've survived.
And I'm very happy that Dr. Mitra always used to say that you will curse us when you are in the department, but when you go out, you will realize what you have learned, and then you will praise us. You will thank us. That's exactly what we have done. Once I left the department, once I finished my MCH and then the chief residency, came back to Hyderabad. That is when I realized what all we had learned in our department in AIMS, which very few other pediatric surgical departments can actually teach such things. And I once had a tiff with Dr. Mitra in my 3rd year as junior resident. when we thought the junior residents, that the 5-year junior residents, we thought we were not getting enough surgeries to do hands-on. So I was wondering how the hell I'm going to operate when I become a senior resident. So that is when we had a long discussion in the duty room with Professor Mitra. He simply said, Chandrasekhar, if I trust you, your surgery, I'll give surgery to you, isn't it? So then I said, sir, have you ever seen me operate? He said, no. I said, then how will you trust me? I was so naive, and I said this to my professor, but he took it in a very, very, very positive spirit. It's not that he started disliking me after that. In fact, after that, he actually saw to it that we actually did a lot of surgery whenever I was in the theater. So whenever I was posted in the theater with him, he actually made sure that we actually did a lot of surgery. And a few years ago, when one of my papers on, I think, laparoscopic duodenal atresia repair in neonates was published, he gave me an email saying that, Chandrasekhar, I'm so proud of you that you're doing all these complex surgeries by laparoscopy. So I felt so happy. I felt on top of the world that somebody who had taught me the very, very basics is now actually complimenting me on my work. So I think we have learned a lot, sir. And I always tell, recently actually I met Dr. N.C.K. Reddy in our state meeting, and I was telling him the most flamboyant surgeon I have seen is Professor Mitra. This is what I always tell people, that the Professor Mitra is the most flamboyant surgeon. I think Tichan agrees with me. He's the most flamboyant surgeon that we have seen, whether it is just a complicated repair like a cleft palate in a small space in the oral cavity, or a ureteric reimplantation where he would just stand outside and take a long scissors and then make the tunnel from outside. when the operating surgeon or the senior resident is struggling to make the tunnel. And I think thoracic surgery, he was extremely good. And he taught us anatomical lung resections, which I think are helping us now to do thoracoscopic surgery, because if you don't know the anatomy, you can't do thoracoscopic resections. So, there is a lot to say, but I think I really thank him from the bottom of my heart. Of course, I thank all my teachers and professors, but today is his day, and he's very dear to my heart. I'm glad that he came to my home in Hyderabad once, and we could pay our respects to him in a very small way. And sir, whenever you're in Hyderabad, my home, my doors are open for you. And thank you so much, sir. Thank you. I wish you a very, very long life and a very fruitful life. Thank you so much.
Thank you. Thank you, Chandrasekhar. Dr. Murthy.
Hello. Good evening, everyone. Sir, can you hear me, sir?
Yes, very well. Go ahead.
Sir, first of all, I want to say before Prabhu, I am the fortunate one who joined as junior resident. Whatever I have achieved just because of this department, and whatever simple few things I have learned from my life is the sincerity and honesty. That is because as a 6-year candidate, we didn't know anything after MBBS. And I joined my MCH pediatric surgery. I took it because after 2 years of my hard work, I got 25th rank. I still remember the day I met him in the faculty room. He told, what is your first choice? I wanted to become a pediatrician. I told him on his face, I wanted to become pediatrician, sir, but I didn't get pediatrics. So I wanted to be a pediatric surgeon. So I took, my second choice was surgery. So I took pediatric surgery. Then he straight away told, you go back and read. Don't come. Don't join department. We don't want you. This is what he told. When I came back, came outside and I went and meet Bal Murugan and everybody in the department, I told them, and everybody told, this is the department you should work. You be there and go back to him, and he changed the decision. And I wanted to continue this department as a MCH trainee. You just tell him, he will allow you, and be confident. That is what I told him on the next week, and he allowed me to join. And I am very fortunate, sir, to join as your last resident. And whatever I have achieved, whatever I am doing right now in Chennai is all because of this department. And you are my first professor who taught me the skin sutures, because I am the last junior resident who was trained under you. I still remember the day you gave me the needle holder and you taught me subcuticular stitches. Still, I owe a lot to you, sir. This because of you people, Dr. Mitra, Dr. Gupta, Dr. Bhatnagar, Dr. Bajpai, and Dr. Sandeep, and Dr. Srinivas. I thank all of you, and I'm wishing you a very, very happy birthday, sir, and wishing you many more happy returns of the days. Thank you very much, sir.
Thank you, Murthy. Thank you. Dr. Mr. Grover.
Thank you very much, sir. Good evening. First of all, let me say my thanks to the organizing team, Professor Bajpai, Dr. Sandeep Agarwal, Dr. Devinder, and all the best. And my colleague, you see, I have the longest association with Professor Mitra. You see, no one else. I am not being a pediatric surgeon, but I have been known as a pediatric surgeon, not in India, but in the world. You see, we have a very close association. 1969, Professor Mitra joined as a postgraduate student in the Department of Surgery, in the section of pediatric surgery. And he did a lot of research work on rats, that is rapid blue induced in antenatal rats. And his work has been, you see, not recognized by in India, but everywhere in the world. You see, he has been trained with Professor Upadhyay, where he was the toughest. That's why you see everybody, why would Dr. Mitra become the toughest? Because these days, that time, all the registrar, they were the only one registrar in the department and one SHO. SHO means not that Thanadar. That SHO means that house officer, ward officer. Dr. Mitra has worked so hard with Professor Upadhyay, day and night. You see, there is a story like that they have to come to collect our ventricular atrial shunt valve tubing. ग्रोवर साहब, मित्रा साहब खड़े हैं बाहर, इनको जरा सिस्टोस्कोप दे दो, वाल्व वो दे दो, सुबह का केस लगा हुआ है, शंट रिप्लेस करना है. मित्रा कितना चाहिए? 20 सेंटीमीटर. He again come and measure 18 centimeter, though by 20 nahi, because child is so small. You see, every time these they have worked so hard that somebody was telling this story, 8.5 hemoglobin. All the time, Professor Upadhyay asked them, what is the TLC of that patient, bed number 20? Oh, Dr. Mitra is not there. He was always asked, sir, 8,500. Then he came and checked next day. What was the... It's really true story. It's not that. And again, you see, he is a very good administrator, very good teacher, very good social. I love him like anything. You see, we always discuss. It's a very long story. I can't say because it's a short time. He is one of the best doctor in the world. I can say that way for the poor patient. If senior is I and Dr. Mitra and other team used to take the round in the morning, whichever the equipment lying idle, he will kill me. Okay, why it is lying idle? किसने नीचे iodine या that something he has गिरा दिया, अपने आप cotton लाएंगे और साफ करेंगे, resident को बुलाएंगे. Then you see there was one blood gas machine in the corner of that old examination room, that old ICU, and in the night they have to do that blood gases, and capillary got blocked. They were blaming each other. Professor Upadhyay used to ask, who has done this? Show me the logbook. Dr. Mitra कहते नहीं, Parsarthi must have done, Murthy has done, that somebody else has done. Everybody was blaming each other, but nobody was accepting that somebody has done that blood gases. That capillary got blocked and your machine is out of order for months because we are not getting that time. She is a wonderful person. I'm sorry, I don't want to take much time. I have a long story for 40 years. He is one of the down-to-earth person. Down-to-earth means down-to-earth. You see, his coat is always there. I have seen this coat for the last so many years. I'm sorry to point out.
The coat वही है.
This is the simplicity of a person. He is coming to achieve that get the felicitation in the AIMS type institute where he has been built up. Okay. Number two, whenever he used to go to the after the round, he used to visit the administration, MS office, medical superintendent office. Why हमें तो ventilator नहीं दे रहे? This ultrasound, this machine, that urodynamic machine is because of him only. First machine in the world, in India, I can say that way. In 1995, we went to the R.K. Sharma. R.K. Sharma was the medical superintendent. भाई शर्मा जी मुझे चाहिए, मैं यहाँ बैठा हूँ. I want something, 9 lakh rupees that time. We were sitting there all the time. उन्होंने कहा मेरे को एक पेन दे दो भाई पेन तुम अपना ही पेन दे दो I will sign and then he has given the pen donate him and then he has sanctioned that funds for the urodynamic machine that Sandeep Agarwal has standardized that machine that way. You see, we have done, now you are using that machine because of that department. We are only having one department, one room only. Now you have a full-fledged maternity and child health center. These are the person they have started that time, 1980. They have started at the time of Professor Tandon, and now we all are enjoying that thing facilities. All these within a few days, everybody will become the professor of pathology, radio diagnosis, neuropathology, everything that you will get that facility because of our senior people. They have worked so hard. It's not so easy. Take the round and go away. No. He will see all the 31 patients, each and every, whether it belongs to Sandeep or it belongs to Bajpai or it belongs to that. And our heartiest congratulations to Professor Bajpai, who has joined as the chairman of the National Board of Examination and chief of that. We have to give him a big clap that our pediatric surgeon has become first time in the history. That now he is the chief director, everything. Now he is the boss of that. Everybody can enjoy that. Thank you very much, sir. May God bless you with long, happy, healthy life. And once again, congratulations for the happy birthday. Thank you once again. I am sorry if I have spoken something. Thank you. Bajpai, congratulations, heartiest congratulations.
Sir, happy birthday you. I think I was the last student who was interviewed by you for the MCH entrance in 2004 December. And बनारसी मुंह में तो मैं चंदन लगा के आया था मंगलवार को इंटरव्यू देने, तो सर ने कहा कि ओह चंदन लगा के आ गए तुम तो वो वर्ड हमको बिल्कुल एग्जैक्ट याद है. सर ने हमारा इंटरव्यू लिया था एंड दैट्स बिकॉज ऑफ यू योर इंटरव्यू आई एम द डिपार्टमेंट एंड आई थिंक एज प्रभु टोल्ड every time we by other senior resident working with you, your story has been heard by many times, and always you are always admired by Professor Bajpai and Dr. Sandeep. Once again, very best wishes for you, sir.
Thank you. So all others who are on the right side, they have not worked with Dr. Mitra. Of course, Shilpa has. She was there in the department when Dr. Mitra was here. But you can all introduce yourself. Which year did you join? Which year? Which kind of course? Pehले Shilpa.
I will take some time, sir, because sir ka jab farewell hua tha, I was there and I could not speak because I was an SR that time. So I will speak now, sir. So I know sir since January 2004, where he came as an examiner, and he got with him so many X-rays, a whole bunch, and my department had lined up 70 cases for him to choose from, and finally it took 1 hour to choose the final cases, and the exam went very well, and he showed me all his X-rays, and 2 X-rays were left. So I wanted to see. He said, "You want to see more?" I said, "Yes, I want to see." And he left those 2 X-rays. He said, "If you want to see them, you come to AIMS." So that was in my mind since January. And then when I finished, I came and I asked him, "Sir, I want to work here." I had to wait for him outside the theater for 8 hours for 3 days. And he would come and he said, "Oh, I forgot. Next day again, he would come. But then he said, "Okay, fine, you can join as an observer." And then he allowed me to join as an observer. And it was really learning experience with him. I used to come at 6:45 a.m. and leave at 7:30 if I was not on call. After that, he gave me SR-ship also. He said, "Why don't you join as SR here?" And there were certain things which I still remember. I used to auscultate the chest of each patient, and he would ask, "Why did you auscultate the chest of this patient?" I said, "Just as a routine." And one post-op day 5, the air entry was decreased on the left side. He said, "How can you explain that the air entry is decreased?" I said, "I don't know, sir." 2 days later, that patient was shifted out of the post-op cubicle and was somehow foul smelling. And everybody had seen and gone, but still I could not get why the patient is foul smelling. So I waited for sir to come out of theater. At 6 p.m., he was about to go back. And I said, "No, sir, I want you to come with me. Please just come." He said, "No, the patient is fine. Everybody has seen." I said, "No, sir, you come." And then he came and I told him, "Sir, he's just smelling odd. The wound is fine, but there is a foul smell." And as soon as sir saw the patient, he said, "There is a leak." It was an esophageal replacement. Shift to theater. And we shifted to theater and the patient had a necrosis of the bowel. Sir did surgery very well. And he saw the way I would assist him, and because of sir's fear, initial knots I would give as granny when he would tell to tie. Sir, don't you know how to put a square knot? I said, sir, I know, but if you have the patience, because it will take few seconds more. He said, okay, go ahead. And then he saw, I said, okay, fine. Now you go to Ballabgarh every Wednesday and teach our residents how to do hernia. So I used to do hernia the way Ganguly sir had taught me, and I taught all the residents that way, step by step. But when I would assist sir, sir would do it with just a small 1 centimeter incision. And I was tagged to Arbinder, and I will ask Arbinder, how does sir know where to go? How does he just reach there and just do it in 5-10 minutes? He said, we don't know, but sir knows how to do it. Then I asked sir one day, sir, how do you know where to put the incision? He says, that is a trick. So you just auscultate the inferior epigastric vessel, and that is where you will find it. And within 5 minutes, and since then I've been doing it that way. Each time I do a hernia repair, I remember. So sir was very fit. He would always take the stairs, and 6 floors, 7 floors were nothing for him. And we all will be lagging behind 4 or 5 of us. And sir would be the first one to reach the theater on the 8th floor. Yeah, so when I joined as SR, the first day I was looking forward to my job. And on the first day when I had to join on 1st of September 2004, at 5 a.m., my 3-year-old child started vomiting, and he had projectile vomiting on my shoulders, and I didn't know what to do. I had wanted to join the job also, but I didn't know what to do. And with very scared, I just rang up at sir at 7:30. He said, what happened? I said, sir, my son is having vomiting. And he told me with such a nice voice, don't worry, jobs can wait. You can join later. So join after 1 or 2 days, let him get well. So thank you so much, sir. And finally, after a long gap of 8 years, in 2012, sir sent an email when I started the public awareness thing. I still remember that mail, sir. Sir said, you carry on with this work. It's really going to help pediatric surgery in future. Thank you so much, sir.
Thank you. Kanika, yeah.
Good evening to everyone. It's always nice to be back in the and come and join any meeting at the department. Sir, I'm Dr. Kanika Sharma. I did my 6-year MCH training. I joined in 2014 and completed in 2019 December. Currently, I am in Banaras Hindu University. I've joined as assistant professor last year. Sir, I've heard a lot about you from Dr. Bajpai sir and Dr. Sandeep sir. We know the kind of decorum, the discipline that our department has and the name that it has. It's because of you. And it's nice to know so many things about you over here.
Sir also taught us the treatment of rectal prolapse, lying down, stool in lying down position for 2 months, which I have not found in any books, but I keep passing it on to residents.
Good evening, everyone. Myself, Dr. Abhishek Ranjan. I joined my MCH course in 2014 and completed on 2016. Right now, I'm working as an associate professor in Department of Pediatric Surgery, RIMS Ranchi. So, sir, आपका RIMS Ranchi, sir. RIMS RMCH सर,
राइट
RMCH सर, आपसे जुड़ा है कि आपने सर RMCH से MBBS किया था, तो अभी सर वहीं पे मैं काम कर रहा हूँ सर एज ए एसोसिएट प्रोफेसर, और हम लोग जो भी कर रहे हैं सब डिपार्टमेंट से ही सीखे हुए हैं और वहाँ पे हर तरह का काम कर रहे हैं सर, और अभी हमारे यहाँ MCH कोर्स भी स्टार्ट हो गया है.
वाह, वंडरफुल सर.
थैंक यू सर, थैंक यू.
Good evening, sir. Many happy returns of the day. So I'm Vikram Khanna. I'm a 6-year MCH student from AIMS. I joined in 2009 and completed in 2015. I'm working as an associate professor in Kalavati Saran Children's Hospital. You are the teacher of teachers, sir. We have what skills we have, where we are now. We are just because of Dr. Sandeep, Dr. Bajpai, Dr. Bhatnagar. And you have been their teacher, sir, and you have endowed them with all the skills and all the knowledge, and they have imparted. And we have tried to squeeze something out of them, and whatever we can take and whatever we can do, I think we owe it to you, sir. Thank you very much.
Good evening, sir. I'm Dr. Kashish Khanna. I completed my MCH from this department in 2016. Then went and worked at Safdarjung Hospital. And then for the last 6 years, I've come back and worked in the department first as a pool officer. And now I'm doing PhD under Dr. Bajpai. So I feel very humble today and very fortunate to have been associated with the department for so long. And I'm really thankful to you, sir, for laying down such a strong foundation of not only this department, but of pediatric surgery in India. I am also take this opportunity to thank all my teachers and my seniors who are here, who have worked together to improvise, to perfect this art and have passed it on to us to pass it further. All the best, sir, for everything in life.
Thank you.
Good evening, sir.
Ankur. After you.
Good evening, sir. I'm Dr. Gaurav. I'm presently a senior resident in the Department of Pediatric Surgery here. I am in the 6-year course. Many happy returns of the day. I just want to add that till this day, we often hear stories about you from our consultants, particularly Professor Agarwala and Professor Bajpai. And thanks to you for whatever you have given us till.
Very good. Thank you.
Good evening, sir. I'm Dr. Ankur Bhartwaj, 3-year candidate. I joined in January 2019 and about to finish it 1 week later. After seeing the teachers you have trained, how great they are, I can just imagine like how much great you have been. And I wish I would have worked under you. And thank you, sir, and wish you a healthy life ahead. So thank you.
Thank you.
Good evening, sir. I am Dr. Nellai Krishnan. I am presently a senior resident in the department. I joined in 2018. So it's been wonderful to know about your accomplishments today. So thank you.
Good evening, everyone. I'm Kaushal Kulkarni. I have joined as a senior resident 3 years course in this year, July. Wishing you a very happy birthday, sir. I'm glad to be a part of this department, of which you are one of the founding strong pillars. Thank you, sir.
Very good.
Good evening, everyone. All the wishes of the day, dear sir. Myself, Delona Teresa. I am a 6-year candidate, now doing 1st year of senior residency in the department.
Good evening, everyone. So many happy returns of the day.
Thank you.
So I'm junior resident here, sir. I've joined in 2021 January. Sir, I'm very fortunate to have attended the conference today and listened great words from everyone. Thank you, sir.
Good evening, sir. A very happy birthday to you. I'm Dr. Shishir. I'm 3-year resident, senior resident in Department of Pediatric Surgery. Joined in year 2020. I'm very fortunate to be associated with Department of Pediatric Surgery. And after listening to all the memories, I feel it's a God blessing to be here. Thank you, sir.
Good evening, sir. Myself, Dr. Monica, sir. I'm a 3-year candidate, sir, who has joined in July 2021, sir. I feel really grateful to work under all these great pioneers, sir. And
good.
Good evening, sir. Many happy returns of the day. I am Dr. Sachit. I had completed my 6 years course last year. I just want to say thanks to you for setting up the ethos and the culture in the department. Thank you, sir.
Good evening, sir. Many happy returns of the day. My name is Dr. Apu Singh. I am currently a second year SR in our department. I joined in 2017 as a 6-year candidate. It's nice to hear a lot of stories about you, and finally to see the legend personified is a great thing altogether. Thank you, sir.
Disappointing, eh?
Good evening, sir. I'm Dr. Mehak Sehgal. I joined the department in January 2017. I'm a senior resident. I feel very lucky to receive one of the persons out of the 2 shunts that we routinely hear about. I get to meet one of them.
Good evening, sir. I'm Dr. Kirtika. I joined here as an SR in January 2021. Very happy birthday to you, sir. And it's very nice to hear so many inspiring stories about you, and we aspire to be there.
Very good.
Thank you, sir.
Happy birthday, sir. I'm Ajay Verma. I joined as 6-year resident in January 2008, completed in 2013. And now in 2019, I joined as faculty. I'm the junior most faculty in the department. और सर हम बस इतना ही कहना चाहूँगा कि
थोड़ा सा मित्रा सबके अंदर में है जो डिपार्टमेंट में है। बस डॉक्टर संदीप के अंदर थोड़ा ज्यादा है।
बहुत बढ़िया, अभी चश्मा यहाँ तक आ चुका है और नीचे आने वाला है।
संदीप ने तो बाद में
Very good. Thank you all. It was such a pleasure. You can't imagine that we have been directly trained under Professor Mitra at that time. Let me hear Bala. I can see you now. Can you hear? Go ahead.
So good evening, sir. So my pranams and salutations to Dr. Mitra. Sorry for joining in late. I've been following the happenings, but I was admitted in as a panelist only now. I think I'll not take long, but yeah, everybody has talked about various aspects of Professor Mitra, but there is a soft aspect to sir, which I think all of us would have experienced. Sir had been very supportive at times of crisis, be it when I lost my father, we came back, very reluctant to come back to Delhi from Pondicherry. Sir was very supportive and made sure that I settled down well. Or be it a time when my son had febrile seizures and we had to rush him to the hospital. Sir was always there, supportive and taking care that we are very comfortable and we don't have to really suffer when it comes to any health-related issues. And of course, there are always nice things Sir does when we write notes well. You can easily pick out whether you have done the examination well or not. And when we do things properly, Sir always appreciates. Or when it comes to documenting the operative notes with nice diagrams, Sir always appreciates and it sort of motivates us to do things better. Three things I always hold to, Sir, because when I finished, Sir gave me three advices. One, he said, get out of the protective umbrella of AIMS, because otherwise my wife was still doing a senior residency. So we took his advice, moved over to Chennai because we were staying away from my son. And that advice, definitely I don't regret because those years will never come back. Second was, Sir advised us that one of you should keep it light. Both of you should not make it hectic. Pediatric surgeon and gynecologist. That also we followed and we are very happy that we were able to do justice to the time we spend with our kids and the family. The third thing, of course, Sir always says, skin sutures, you may never use forceps for subcuticular. It was very difficult to start, but then I think I followed it till day and I don't let my residents also use a forceps when they have to hold the skin to take the subcuticular. Says you have to do it without holding the forceps. There's nothing, we were not learned during our 3 years, be it pediatric surgery related or be it life related. And I'm always proud to say that I've been your student and I carry the lessons learned in pediatric surgery through you or life lessons, the advices what you have given us, and that has shown us the road ahead, sir. Happy birthday once again, sir. Thank you, sir.
Well, thank you, sir, for coming and gracing this occasion. And we are all delighted to have you and hear these small snippets. There are many more, I'm sure. Everybody has a lot of experiences with you during their tenure here. And we, Dr. Bajpai and myself, try to pass on the good things that you taught us to the residents now. And often, as they told, we always say that, "Ye Dr. Mitra ne sikhaya tha, isko aise karo." We still do it. And we talk a lot about old, not only patients, but a lot of old things which happen in the department. And there's some good thing that whenever we go for annual conference, we try to get together as a alumni. And then that transcends the ages, the years, and people know that these are the people who are from this department. Thank you, sir, for coming.
One thing more, we have all heard about he was a very hard taskmaster and he was very strict. He used to come at 8 o'clock. When we entered, naturally he was sitting there. कुछ कहते नहीं थे, लेकिन समझ में आ जाता था हम लोगों को कि और पहले आ जाते तो शायद अच्छा होता. And he used to see that we were 3 or 4 residents. 4 residents जब ड्यूटी पे होते थे तो it was a luxury. 3 ही होते थे हमेशा. एक छुट्टी पे जाता था कभी तो imagine करो. And we used to do all the work, taking calls, doing ward job, etc. सब होता था. Because he was there to see that we are able to accomplish everything and complete everything. अभी हम लोग 4 ड्यूटी पर तुम लोग को लगाते हैं. आप देखो अक्सर काम रह जाता है. We have to put in one person 12 to 12, फिर overnight लगाते हैं, फिर call के लिए कोई अलग जाएगा. Because probably it looks like we are not able to extract the work, which you all probably are capable of. But डॉक्टर साहब ले लेते थे हम लोग से काम. And this speaks a lot. And he was very rewarding. आप समझ सकते हो how much hard work we had to do. but that was a norm. And he was his words were very rewarding. मैं एक example दे रहा हूँ. अक्सर emergencies पड़ी रहती थी, उसमें 4 तो shunt revision होते थे और 2-3 और भी केस होते थे रोज. And एक बार 7-8 cases piled up हो गए थे. और डॉक्टर साहब हम ड्यूटी पे आए, डॉक्टर साहब ने कहा इतने लगे हुए, he used to keep account, इतने केसेस हैं, इस पे ये है. तो हम लग गए. अगले दिन सवेरे आए तो हमने कहा कि सब हो गए. बोले वाकई सब हो गए कैसे? क्योंकि वो पाइल्ड अप हो रहे थे, किसी की ड्यूटी पे नहीं हो पाए, 2 रह गए, फिर एक और रह गया, ऐसे करते करते 7-8, और सब कुछ हमारी लक अच्छी थी कि सारे रात में निपटा दिए. He was so rewarding. I mean, his words, बस खाली कंधे पे हाथ रख दिया, जी सोचो पूरी जहां मिल गया. So that was the kind of thing. I mean, if we are a hard taskmaster, if we tell you something, we mean good about you. You have known now that how everybody across the country, some of us are abroad. We remember him because at that time अजीब सा लगता है, but जब बाहर जाते हैं, even NCK Reddy, who's so senior, formerly head of the department, Professor Kulshesh, डॉक्टर साहब जो बहुत इनके मित्र भी रहे, बहुत पुराने. और so I think it all makes it. Sir, मैं तो पहला अब आप थोड़ी सी रह गई बातें आपकी, बताइए.
I was his first resident because he became faculty when I joined as a senior resident for MCH. And that time we were very friendly. And that time the Professor Upadhyay, a case which he used to do in 3 to 4 hours, he will finish it in half an hour. And the reason was, if you assist some case with Professor Upadhyay, you will learn anatomy, physiology, operative techniques, and complications, and how to treat those complications. And sir ke saath practical, how to do it. So that was the advantage at that time. So and we were very free at that time. That time he was not tough taskmaster.
I want to tell you what flamboyance in surgery means.
Yes.
So you have to understand that you have to have your theory right. You have to have your diagrams right. You have to have a 3-dimensional view of what is going to happen in OT right. Yes. Then you go and there's a cleft lip on the table, and then Master Yoda comes with his Jedi sword, and there are no dots, there are no lines, there's only shish, 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 and he says, Suja, and walks out. And then you're like, okay. Then you realize that the reason why you go through that every day, the questions, the lines, those dots, those markings, is because your performance in the OT has to be swift and exact, precise. And to me, that is something where you get the compliment. You don't wait for, acha beta, khana khaya, nahi khaya. No, it's like, okay, that kid, I'll never forget, baby Seema. If Jayanto is watching from this thing, CDH, always in trouble. The biggest compliment I received from Dr. Mitra was, ye bacha, Tichen, you can't go off, you stay. That is the biggest compliment any teacher can tell you, because it means that he trusts what you do and you have learned what he's trying to tell you. So for that, eternally grateful.
The same thing happened when we were doing one pheochromocytoma, and those times the monitors were not there. So many monitors were not there, and Dr. Call said, "बड़ा बच्चा है, हम AV8 ICU में रख लेते हैं रात के लिए." तो सर ने बोला कि नहीं, हमारे पास बहुत अच्छा मॉनिटर है और आप चिंता नहीं करो, we will take care of in the ward. तो वो मल्टी पैरामीटर मॉनिटर है, रिस्पॉन्स भी देता है. तो मैंने सर से पूछा, अब स्क्रब था साथ में, मैंने पूछा सर नया मॉनिटर आया है, कोई ऑफिस से निकालोगे? सर तुम साले बैठोगे रात को. So those are the things which actually, hard taskmaster is okay, but for the correct things.
There is nothing for me to say now. Everybody has said many things, and I hope what they have said is true, at least partly true. I know that to many of you will be saying with his hand like this, Sala. But believe me, whatever I did it in a good faith. I wanted to help you. I wanted to bring you up so that later in life, you can run your own department. And I still receive mail from people, especially Arvinder. He says, sir, we now realize what we have learned.
Yes,
correct. So the thing is that please do whatever you're doing with your heart, fully, not just to show that you are doing something. I won't take much time. I know you are all getting tired. It's already quite late. And second thing is about my age. Age is an issue of a mind. Okay. And it doesn't matter. If the mind is okay, the age doesn't matter. So don't worry about the age. I'm still as young as I used to be. Given an opportunity, I can do that.
Thank you very much for giving me this opportunity. Now give the award to him.
Thank you.
सब लोग आ जाओ सब लोग इधर कुछ लोग आगे तुम लोग आगे आ जाओ आगे आ जाओ टेलो ना आगे आ जाओ कुछ लोग यहाँ आ जाओ कुछ लोग यहाँ आ जाओ
आ जाओ कनिका आ जाओ
स्क्रीन हटा दो तो
कशिश और शिल्पा आ जाओ इधर बैठते हैं
स्क्रीन हटवा दो तो लोग चुप जाएंगे
ये सुनो ये स्क्रीन जो है साइड हो सकते हैं
फोटोग्राफ में कट जाता है
फोटो
वीडियो बना देगा कैमरा में
थैंक यू जिंदल बाहर कैसे खड़ा है जिंदल बाहर कैसे खड़ा है
इधर खड़ा है
यहाँ खड़े हो तुम्हारा डुप्लीकेट भी लाए हो क्या नहीं सर वो यहाँ कोई जिंदल टाइप का ही है कोई
डुप्लीकेट होगा
चलो
थैंक यू वेरी मच